record up. So as I said, this is our third clinical orientation and mentorship program, which will be starting on Friday on 1st of April. And I'll be doing the first session. And then we've got multiple sessions going on for the duration of 6 weeks. So I'm very excited about it because I think this program is more tailored towards the needs that have been articulated to me by various IMGs. And we'll talk about that. So first and foremost, this 6-week clinical orientation and mentorship program, what is it? This is what we're going to be talking about. Why is it so important for us IMGs to be engaged in this kind of program, and how will it be delivered from my end? And what we'll do with the cases, we'll do some of the cases because that will give you a more realistic idea how we actually conduct our sessions. And then we'll talk about the medical jobs, in particular the application process and the interviews and some regulations. So we'll start off quickly. We've got a long session ahead. So in the interest of time, because you may have commitment, I want to also finish this early. So what is clinical orientation? You know, most of the states here in Australia, in fact, all of the states in Australia have got orientation program for their junior doctors. In fact, I remember when I was working in the NHS, I had an orientation program when I started my first job. And that was for all the doctors who are starting the job. And that orientation programs actually tell them how the hospital works, how to request the test, some of the common cases that you're expected to see in emergency, what would be the commonest ward-based emergency, and how to tackle them. What are the hospital emergency paging numbers, and so forth. Does that make sense? Good. But the issue with these clinical orientation, which are hospital delivered, is that they are very brief. They would only be for a few hours in some hospitals. And sometimes they might only be, or maximum they would be for a day. When I did the clinical orientation about many years ago, it was only for a day. All right. So that is something to keep in mind. They are brief, they are to the point, but they're more geared toward the people who are actually either working in the system or the production of the local system, like local medical graduates, like local doctors. It's not for someone who is actually an IMG from some third world country. These programs are helpful, but not really helpful, because our problems is twofold. We're also trying to understand the local health system, and we're also trying to brush up our practical skills. So hospital orientation programs are definitely good. It is a quick summary, but they're more suited to the local graduates. That's the feedback which I got from different people who joined the recent hospital program. So what are we doing, or what we have done in the last year? We had initially an 8-week program. Okay, it was a lengthy program, 3-hour sessions. We had sometimes in excess of 4 or 5 sessions in a week. And obviously, some of you are working, preparing for an interview, preparing for an AMC exam. So it was very difficult for keeping up with all what is coming in. It was a lot of information. In fact, feedback was excellent. Everybody enjoyed. You all became a part of my family in those 8 weeks. But what actually happened is that people would miss a session, then they would say, oh, I've missed a very important session. What we have done now is we've tapered it to 6 weeks. So we've plucked out even more important topics, the most important topics that you'll see in 6 weeks. 50 most common cases that you'll see in the hospital, that stays exactly the same. These are the cases that you'll see in emergency department. These are the cases that you will see in the wards, wherever you're working as a surgical RMO or a medical RMO, whatever you're doing. These are the cases you will see, definitely. And a complete management. And when I say management, it's also the assessment, like how to take history, examine the patient. You'll be role playing in those spaces. And the management, not only from the point of view of stabilizing the patient condition, but also talking to the patient, to the relatives, making a more holistic plan in terms of referral, retrieval, all of that. And we'll follow the guidelines, which are national guidelines. Now, by and large, the guidelines are quite similar when it comes to managing the patient here in Australian hospital. There might be slight tweaks here and there, but generally they are quite similar. Now, in terms of what else we do in our program, we do something called grand rounds. So basically, if you're joining the program, we'll get you to present a case from your own practice, or we'll give you a case and a template. So in 10 minutes time, it will boost your confidence to how to present a case. Now, there are other things which are very important and we tend not to think about it, and there are clinical governance, communication and risk management, which are actually very deeply embedded into our system. Let me just have a quick look. I think there is some people who might be able to coming. Oh, what is so basically for this what is the cost of the course and how can we join? So basically, emergencyfocus.net is the website where you can jump on. If you click on CPD clinical orientation course, it would be there. The cost is $500 times two, so it's paid in two installments. The total cost is $999, which is paid in two installment and includes the workshops as well. We'll go and talk about that now. So why is an orientation program is important in 2022? Anyone tell me? You're all there, it is for you. Why do you think an orientation program is more important this year? Tariq, what do you think?
I think if you are aware what you can expect when you start working as a RMO, and I think this is the best platform. You go through it, 50 cases plus the communication,
Yep.
plus how to document things, and so you're nearly there, and then
Mm.
you can learn when you start working simultaneously, and
Mm.
yeah.
Plus the jobs. Have you heard how many people have got a job now? It is amazing. Like I have been flooded with the messages. um, IMGs getting jobs now. So this is the best zone to be in Australia. Because of the border restriction, not many UK graduates have come to Australia. uh, those were the default choice for most hospitals. So because there are deficiency of UK doctors or US doctors or Canadian doctors, they've not come joined in. They are now picking up local IMGs who are ready. They have got no recency requirement. They are registration ready. They've got CPD in order. Give them a job. And I have heard many, many stories, successful stories of the people who have been waiting for 7, sometimes 8 years, and they've been able to get a job after AMC 1, but also AMC 2. So both in the context of limited as well as provisional registration. Okay. Okay. All right. So this program is a complete roadmap. I often say, um, if you give me 150 hours of your life completely with the utmost dedication, maybe we can achieve your goals together. And those 150 hours are both for the preparation in terms of orientation and also from the AMC clinical point of view. This is essentially all you need. All the workshops, all the orientation, all the matter is already in there. But these 100 hours, I was reading a book yesterday. It was a very interesting book, and it started off by giving an example about Roger Federer and Tiger Woods, that these are the people who actually trained in terms of quantified hours, and after a certain number of hours they become skillful, they achieve mastery. Now, different people would have different sort of sets when they become masters of their skills or master of their trade, but it would happen if you do it with dedication. So this is a complete roadmap. Um, we are going to be talking about the cases in terms of how to role play, in terms of taking history, in terms of ordering investigation, and as I said, management, not only from the point of view of stabilization, but also communication, sealing of care. So it is very holistic. Day before yesterday, I was working on the floor in the COVID ward, and there was a GMO. She was from Bangladesh, and we had a patient who was elderly, COVID, poor SATs, and all that. And I said, why don't you go and talk to the family in terms of sealing of care? And she did that remarkably well. These are the discussions you will be having because we are having more and more geriatric population in the hospital. So you will be engaging these discussion in your AMC clinical. You will be having an issue discussion related to, sealing of care, giving bad news, all that conflict resolution. So it also helps you in your clinical role play. That's what I'm trying to say. All right. If you're planning to sit your AMC clinical this year, this course would be perfect for you because most of the cases are all practical. The components of the history taking examination, investigation, and management are ditto the same. Um, we are more practical, we are more in depth than AMC Clinical 2. And we haven't got that time constraint as to, you have to get it done within 8 minutes. We can stretch our boundaries because we want to create a level of understanding. Um, and we give you feedback. So when you're doing a role play, I'll give you feedback that look, Tarek, Dr. Kavya, this is what was good. This is what can be done better, and this is how we can achieve that betterment. All right. So it is very good. And I often say to my doctors who are in clinical orientation course that when we are doing the medical application CV, I want you to attend those workshops and modify your CV. All right. And when you get your interview call from the hospital or email, the first call you should be doing as the participant of the orientation program, call me so I can book in a dummy interview for you. All right. And I've done this with multiple participants last year, and Alhamdulillah, they all got like jobs. So, or at least if not that one, then the next one. So this is very important that we support you throughout that process of getting a job because I think if anything defines the success or if it's a measure of an outcome of any program is you getting a job and obviously passing the AMC in that process as well. And plus, CPD hours. You're sitting home, you're not doing anything. This is something which is going to get you across. 50 CPD hours, more workshops, keeps you in tones, and it's well recognized in terms of how will it be delivered. Live session, 2 hours, mostly Mondays and Wednesdays, so 10 till 1. We got a couple of doctors, me, Dr. Fazia, Dr. Erin. There would be some other faculty who would be joining us as a guest faculty as well. You will have an access to portal with the reading material of all the cases, plus guidelines, plus all the recordings will go into it. So you can access those. Don't make a habit of, and just accessing the recordings only, because that's not where the learning is. That's a backup plan. That's a stepney. Tariq, you understand the stepney? Like a spare wheel.
Yeah.
So, yeah, so that's a spare wheel, but the actual learning is the real four-wheel drive tire. Okay. So let's do that. Now, the workshops are very important part of this course. The included workshops are adult, pediatric, and application CV and interview. There are a few workshops which are now optional because that will save you time, that'll save you money, and you can book in those. The workshops will be in the timetable. You can, if you want to do a professional medical communication, documentation, cardiology, psychiatry, you just register as an extra. And they're all on the website emergencyfocus.net. All right. Any questions before we jump on to do some clinical cases? Oh, by the way, let me check if somebody else is waiting in the waiting room. I must be just, completely ignoring the people who are in the waiting room. Oh, yes. There we go. All right. Any questions at this end? No. All right. Perfect. So we'll do some clinical cases. Who is going to be my volunteer? Come on, we'll do it together. It will be fun. In the spirit of the fun, put your hands up. Be gutsy. And you know that yesterday I was at some place in this IMG. They were all get together, and one of the IMGs came to me and said to me, sometimes we need pushing because every time when we're doing our AMC course and clinical scenario, everybody sits quiet. Okay, so there are a number of candidates in that, but everybody sits quiet. Oh, she will do it, he will do it, but everybody should be jumping in rather. Anyway, we'll start.
I'm ready to
All right,
volunteer
Dr.
myself.
Nida. Excellent. So, Dr. Nida, would you like to read the case then, if you can see the screen?
Yes. An 82-year-old lady with Tracy Smith has been brought to the hospital
Now, can
after
I
having.
request whoever is not participating or speaking, can they turn themselves to mute so that we don't get any interference, please? Thank you. Thank you. Thank you. Thank you. Thank you very much, guys. All right, perfect. We've got about 30 plus participants, so there's a lot of background noise, and we'll try limit that. Okay, Dr. Nida, go ahead, please.
An 82-year-old lady, Tracy Smith, has been brought to the hospital after having a fall. She uses a walking stick and says that she has probably tripped on the edge of the carpet. She has some injuries to her face, forearm, and right leg. Her
Yep.
vital DP is 130 by 90, heart rate is 100 per minute, and saturations are 98%, and afebrile.
So your
And
task
task
are
focused history and examination, plan appropriate investigations, and management and disposition.
perfect. Perfect. So you understand what it's all about, Dr. Inda?
Yep.
All right. Okay. Excellent. So I'll tell you how so this is how exactly we'll be doing the clinical orientation course cases. I'll give you the case scenario. I'll get you to think about the case scenario, that what is happening. All right. And what is going through your mind in terms of planning. Just as we do the AMC clinical scenario, you think about in your mind, when I walk into the room, this is the question, these are the questions which I'm going to ask. This is my examination priorities, and these are my investigation and management priorities. But there's more. And I want you to focus here. I want you all to pay attention. We're going to be talking about key historical, key investigation, key management. So, not everything, but just super focused. Because one of the things that um, is very upsetting to see the doctors on working in the hospital when they get a job is waste a lot of time about the information which is not relevant. In the hospital, time is really important. You'll be looking after 20, 30 patients. So you need to be very super fast. So whenever I say do an assessment, 5 key questions in history, 5 key examination findings, one coming up to, one working diagnosis and 4 differential diagnoses. And that's what the AMC crux is as well, that you should have, the 4 differential diagnoses and 1 clinical diagnosis. And then key investigation and why you're doing those investigations, right? Okay. And then finally, management and disposition. What does disposition means, Dr. Nida?
Uh, I'm not sure.
So disposition means whether you're going to admit the patient or you're going to discharge the patient. So remember this terminology, disposition. And finally, clinical handover and follow-up. All right. So you can ask all the questions you like, but there are 5 questions in the history which I have got on my paper as, as a consultant, as an examiner, and I want you to tell those or ask those questions must, because there are, like, you can say pass fail criteria when it comes to AMC. So we are like super focused and super sharp here right now. All right. So go ahead, please ask me what happened.
Okay. Can you please share the question again?
Yeah,
So that
sure. There you go.
yeah. So first we need to introduce ourselves.
Mm-hmm.
Hello, my name is Dr. Nida, and I'm one of the doctors working here and looking after you at the moment.
Yep.
So how are you, Mr. Stacy?
Oh, doctor, I cannot tell you. I've really had a fall. I don't know, silly me. I was, getting up from my settee and I must have tripped on the carpet and I had a fall. I really don't know what happened. It was just so quick. And yes,
I'm so
I've
sorry to hear
fallen.
that.
Oh, doctor, really, I'm so stupid at sometimes.
Oh no, it's not a problem. So don't
It's,
worry. I will. Do
so,
you? Do
Dr.
you?
Neda, don't say that. It's not a problem that you've been stupid.
Sorry. Yes.
So no,
Do
I'm
you?
actually, I tell you one thing, I'm actually saying exactly as the patients would say things, right? So
Yeah.
this is
I
important.
understand. I understand your
That is
concern.
right. Yeah,
I
I
understand.
understand that these things can
I
happen.
will
I
definitely
sympathize with you.
try.
Go ahead. Yeah.
I will definitely try to help you. Do you need any painkiller at the moment?
Oh, thank you, doctor. That would be excellent.
Okay, so let me uh, let me ask my nurses to give you some painkillers. Okay, are
Thank you,
you
doctor.
okay? Can we start our session, or do you want first painkiller?
No, that's
Or
fine. I've just been given some painkillers by your nurse, so I'm all good now. Thank you.
so thank you. So can you please tell me exactly where the pain is present?
Yeah, so I was sitting in my lounge. I was trying to get up from my lounge to go to the kitchen to fix myself a morning tea. And, the carpet is uneven between the kitchen and the lounge area, and I must have tripped off. I use a walking stick. So sometimes, my balance is not great. And at times, my right knee, there's a lot of arthritis in that. I don't know if it's the knee which gave way or I tripped between the uneven surface or if it was my balance. I'm just really not sure.
Okay. So this is your right knee? Is this on
Yes,
your right
yes,
side?
doctor.
Okay.
Yes, doctor. Yeah.
And is it? Can I touch your knee if it is okay with you?
Yep, you can. It is very
Oh,
sore though.
yeah, I will be very gentle, so don't worry. Okay.
Okay,
Let me
doctor.
know. Let me know when it hurts. Okay.
Okay,
Uh,
doctor.
okay. So is it painful?
It is very painful, doctor. Yes,
Okay.
it's very
Okay.
sore.
Oh,
I've just been given some painkillers, so yes, it is
yeah.
getting
Yeah.
better, but
It,
yeah, it
it
is
will
quite
take.
sore.
It will take. Maybe half an hour to or 15 minutes to work, and
Okay,
then the
doctor.
painkillers will. It will be
Sure.
fine. Okay.
Okay.
And I can see that you are having some injuries on your face and forearm as well.
Yes,
Uh,
doctor. Yeah.
and have you applied anything? And did you wash your bleed part, or is it was it bleeding as well?
Look, there's no bleeding. Is that what you're asking about the bleeding?
Yep, yep.
No, there's no bleeding, but a lot of bruising there. I'll show you in the next slide some of the examination findings. Okay.
Okay,
So we're
okay,
just
okay.
asking question in terms of the history, past medical history, drug history, allergy,
Yes,
social history, and we'll talk about the
yes.
tools.
And do you normally wear glasses?
I'm sorry. Yeah. Look, I mean, I don't wear glasses. Just the
Mm,
reading glasses.
okay. And when you trip, have you got any headache or any dizziness?
Yeah, I do have a little bit of headache. Yes, I mean, after I had a fall, I did feel a little bit dizzy, but I didn't have any vomiting or anything like that.
Okay. And when you fall, did you lose your consciousness?
Doctor, I don't really remember if I lost consciousness. I may have briefly passed out for a few seconds. I'm not sure. I'm sorry.
And was there anyone with you at that time?
Hmm.
Was
Sorry.
anyone with you? Was anyone with you at that time when you fall?
No, I live by myself.
Okay, okay. And when you gain your consciousness, were you able to get up by yourself?
Yeah, so I was able to get up by myself. I reach out the phone and call the ambulance because it
Oh,
was quite sore. In fact, no, I remember calling my son, who's
uh-huh.
actually outside in the waiting room, and he called the ambulance because he was quite worried about me. He was at work. He said that he'll meet me in the hospital.
Okay, okay. And at what time you have your last meal?
Oh, I've had breakfast at about 7 o'clock, so it's about 10 o'clock now, 10:30.
Okay, okay. And had you had a like good sleep at night?
Sorry, good sleep at night.
Good.
Yes.
Yeah, yeah. Okay, okay. Anything else you want to tell to me which I forgot?
Just a bit concerned. Look, I mean, I've never had a fall like this before, so I'm a bit worried about why I had a fall. So
And do you have,
yeah,
yeah, yeah,
and I
and
live
do
by
you have
myself. I
any?
don't want this to happen again. So that's the other thing.
Yes, yes, yes. Don't worry, I will definitely help you in this way as well. And do you have any medical condition?
Look, I have got arthritis in the right knee, as I told you. I do suffer
Yeah.
from high blood pressure, and I also use a walking stick because of the balance
Mm.
issues and all that. Yeah.
Since how long you are using walking stick?
I have used a walking stick since the arthritis has gotten worse in the last 6 months.
Last 6 years?
6 months.
6 months. Okay.
Yeah.
Okay. And what medications are you using at the moment?
So I'm on amlodipine for high blood pressure, 5 milligrams. I'm also on Panadol Osteo or paracetamol sometimes, two
Mm-hmm.
tablets 3 times a day.
Mm-hmm.
And yeah, and that's pretty much it really.
Okay. Okay. And and do you have like frequent spells of like this trip down, or is it something new?
I'm sorry, I didn't get that.
Do you fall like oftenly? Like
No, no, this is the first time, doctor,
this
I've had
is
a
the
fall.
first.
I've never had a fall before.
Okay, okay,
Yeah, yeah,
okay.
yeah.
And sorry to ask you, do you drink?
I I don't drink. No,
Okay, okay. And any history of smoking?
I don't smoke, doctor.
Okay, thank you for this. And
All right, I think we'll leave it at that. Thank you very much. That was quite good. So the things which I had in my directory
yeah,
were
yeah.
the things about mechanical versus non-mechanical. So we must establish this fact quite early on, that because this is not really clear whether the history of fall might be because the balance issue, because it could have been because of trip and fall, could she been dizzy, could this be arthritis giving causing the knee to give up? So this is unsure. We could not really establish whether it's a mechanical or non-mechanical fall. The other thing we must do as a doctor on the floor is check about the pre-fall symptoms, any chest pain, any shortness of breath, any sudden episode of dizziness. I think you did ask about the dizziness, but just inquire about more in terms of differential. Like, did you have any palpitations or feeling like as if you're going to pass out? And any post-fall injuries. Yes, she's got head injury, right arm injury, and right leg injury. Recent falls you did inquire about, and contributors, obviously. If she's had multiple falls because of poor mobility, if she got dementia, multiple medications, they all are contributing to falls. And also a UTI, and you did inquire about the social situation. All right. Okay. Thank you very much, Dr. Nida. I'll get you to mute yourself, please. And anybody else who would like to participate in examination side of things? Okay. Would somebody just go through the examination quickly? So we'll move on.
Yes, sir, I can go.
Who's I? Okay, Bushra. Thank you,
It's
Dr.
Bushra.
Bushra.
Yes.
Okay, okay. All right.
Uh,
So, how would you like to examine this patient?
Okay, so first of all, I'll generally look at the patient, the general examination, the level of consciousness, is he alert, and is
Yep,
he able to perform some simple tasks? Then I
yep.
have to start the head to toe examination,
Mm-hmm,
quickly listen to the cardiovascular system,
mm-hmm.
because if I were asking a history, there could be cardiac arrhythmias, which could be the cause of this.
Very
So
good.
it could also, and while I'm doing the chest, I will also do the respiratory examination, again, for any respiratory things which I might have picked.
Mm-hmm.
The next thing which I'll do is the neurological system, very important
Very
because it
good.
could
Yeah,
be any strokes, etc.
that's right.
So cranial nerves, for cranial nerves, tone power, reflexes, sensations, or coordination is really very important. So
Very
although
good.
he's not drinking, but
Mm-hmm,
we'll do it. Then as I'm going head to toe, so I'll do the the GI examination as well.
mm-hmm,
Quickly check the abdominal. Is there any tenderness, any rigidity, organomegaly? And lastly, as he is mentioned that he has arthritis, he has some injuries, so it's very important that I look at all the injuries and the
very good.
musculoskeletal examination around the knee. It's really where what's the swelling, what's redness, swelling, a range of mobility
Mm-hmm,
around the joints. So it's really very important. ENT is also very important
mm-hmm.
because it might be related to the balance issues. We can also examine her. Preliminary eye examination can also be done. Yes.
Very good. Very good, Dr.
So,
Bushra.
and for the bedtime, I can do the green dipstick and all.
That's good.
Uh,
So that's excellent. I think you've pretty much nailed everything which I've got on my list. Now, what we can do, Dr. Bushra, is to improve it. So whenever you're
Okay.
starting in terms of general awareness, you also do vitals and postural blood pressure and heart rate. So this is a patient who's come in after a fall. Could it be related to
Hmm.
postural hypotension? Because
Yes.
elderly people don't have that autonomic reflex tachycardia response as strong
Hmm.
as the young patients would. So that's very important to check the postural blood pressure and heart rate. You were absolutely spot on with the focal deficit and cerebellar testing, very important, um, especially the cardiovascular. And when I say AS, what do I mean?
Aortic stenosis.
That is right. So you would be surprised. Aortic stenosis severity, exertional dyspnea,
Yes.
exertional syncope, exertional
Yes.
chest pain. So
Yes.
we must consider, and what type of murmur is that of aortic stenosis? Anybody?
Um, that
Injection systolic.
Injection
Very good.
systolic.
So
ejection
ejection
system.
systolic murmur. And where would you listen to that murmur?
External border.
Paratics.
Yes.
Upper
So sternal
sternal border.
border,
Mm.
yes, on the right side. Okay, perfect. So you need to listen to any of the systolic murmurs, especially from the point of view of aortic stenosis, because aortic stenosis is one of those diseases of elderly. Their valves get calcified. It may be stenos. It might not be generating or letting the blood supply up to meet the body demands. Okay, and chest is important because it might be related to lower respiratory tract infection and injury and mobility assessment. Now, Dr. Bushra, I'm going to show you the images of this patient. And if you can make a brief comment, starting with the face, arm, and then on to the knee, please. So imagine you seeing this patient at the bedside now. You there, Dr. Bushra?
Sorry, yes, I was mute. Sorry.
Or okay.
Okay, so
So
on the face, I can see there is a bruise
yep,
on the side of the face around the eye.
yep.
And also on the hands, there are multiple bruises. Uh, um, the two bruises, large bruises, which I can see, and also there's a huge bruise on the knee as well.
Perfect. So there seems to be injury sustained onto the right
In,
side of the hand,
on the
face,
right
and
side,
the
yes.
knee. Yep. So what is your main working diagnosis and differentials based on that? What are you thinking about? So in hospital we work on the balance of that, what could have happened and what needs to be done. So when you're working in the hospital, when you'll get a job, and if you're working in the hospital, remember, we always think about what could be the diagnosis. So what do you think is good, the diagnosis there?
Um, it's a mechanical fall.
Yep.
Um, um, Most likely, it could be due to various issues like the eyesight, the social situation. We have to look for the social situation because there might be poor lighting as well.
So
So
let's just
most
stop
likely,
there. That's
yes,
very good. You started off perfectly. It could be just a simple mechanical trip and fall.
yes.
All right. But we're still thinking in terms of pathology. We'll come to the social issues later.
Okay.
But in terms of pathology, what else could be? So mechanical fall is one reason of a fall. What could be the
Hmm.
other reason of a fall?
It could be postural hypotension because
Very
she
good.
is hypertension. She is hypertensive and
So it
taking
could be a cardiogenic
antihypertensive.
syncope or a neurogenic
Yes,
syncope. Perfect.
yes,
Perfect.
yes,
Thank you. Yeah, that was awesome. And it could
yes.
be right knee, giving way
Yes,
because she's got a
arthritis.
fair bit of arthritis. She may have
Yes.
like more injury, as we've talked about cardio and neurosyncope. And one more thing, who else is going to think about hypoglycemic episode? Yes. Dr. Koila is saying yes, yes, that could be one of those. Cerebellar problem,
Vasovagal
yes. Vasovagal syncope could be there as well. And
could be a TIA,
what is, sorry?
TIA, like a Marshall.
TIA could be, yes,
Hmm.
exactly. It could be cerebellar TIA. But one other thing which you must include, exactly, Dr. Tariq said it right,
Polypharmacy.
UTI. UTI.
Yes.
So you must think UTI or, any of the infective issues which might
Delirium.
be causing. Delirium could be from the UTI, yes, but the patient is actually giving the history and actually quite succinct, so it's unlikely. One more thing, if you tell me this thing, I'll think that would be gold.
Polypharmacy.
Polypharmacy, yes, we talked about vasovagal, polypharmacy, cardiogenic neurosyncope. I would broadly classify that in that category, but there's one thing which is an
Dementia.
entity on its own. Dementia, yes, we can talk about that, but there's
Anemia.
one anemia, yes. There's one other thing which I want you to think about, not particular to this case, but in case of any injury.
Elder abuse. Elder abuse.
Yes, excellent, excellent. So elderly trauma, neglect, or abuse is more common than we think. Okay, they might be coming from the nursing home, they might be coming from their own home in which they're living, because care of an elderly who is specially demented or who has got special mobility requirements, and in a large family or by even a small family looked after by they could be often neglected and there could be a component of abuse. So always include that in your differential. Make sense? Perfect. So who's going to do the investigations for me quickly? No one wants to play. Everybody wants to leave me by myself.
Can I do it, doctor?
Go for it. What's your name?
Rabia.
Thank you, Rabia. Yeah, go for it. What
So
investigations are
we'll
you going to do?
start with the basic baseline investigation, complete blood count. And we'll look at the urea electrolytes to rule out any postural hypertension or electrolyte abnormalities.
Very
We will
good.
also look at the urine complete examination and culture to rule out infection.
Very good.
And then we will go for the imaging.
Mm-hmm.
We will look at the chest X-ray to rule out any pathology of the lung. We will do ECG. We will do echo to rule out any structural abnormality
Very
for
good.
and
Very good.
CT scan for TIA and stroke.
Mm-hmm.
And for postural hypotension, we will do ambulatory blood pressure monitoring.
Okay. Now, ambulatory. Now, we're not quite sure if the patient is going to be admitted or discharged, but yes, I take your thought as a valid one. Now, Dr. Rabia, that is excellent, but let's just organize that again, shall we? So,
Okay. Yes.
organization is we broadly divide the test as bedside, laboratory, imaging, and special tests. Makes sense, right? You'll never miss a test again. So bedside, you're right. You can do
Yes.
ECG, you can do VBG, you can do a bedside echo. Laboratory wise, instead, did you mention troponin? You missed troponin, right?
Yes, I did. Cardiac enzymes.
So exactly, it must think about troponin for any unexplained, fall, syncope, could be a cardiac syncope. Even though College of Emergency Medicine say that troponin is not required for syncope, but if you've got an unexplained syncope, especially if the ECG changes, you must do a troponin. Imaging, you're right, CT brain in terms of bleeding. There could be an X-ray, obviously, for an infection and all these things. So investigations are coming back, Dr. Rabia. There we go. Can you see the ECG? Is it visible? I'll blow it up for
Yes,
you.
it is, sir.
Okay, what do you think about the ECG? Looks normal, right? I'll save you that. So the ECG is normal. It's a normal sinus test.
I'm sorry,
Okay,
I'm very bad at ECG reading.
that's okay. We'll work on that. What about the CT brain? Looks normal as well.
I
So
think it's normal.
I don't have to
Yeah.
put pathology every time. I think I want you to be, and the reason for that is that, by and large, majority of the patients who will come into the hospital and will get the gamut of investigation, most of those investigations would be fine. That doesn't make them less severe in terms of their risk assessment. But then again, it is there as a practical, tip that you can have normal investigation, but still you have to think about other things. Now, in terms of the knee, anything there? It's an AP and lateral of the right knee.
Some osteoarthritic changes in the knee.
Yeah, there could be some
Other than that,
osteoarthritic
I couldn't
changes, reduced
appreciate
joint space,
any
but yeah, there's no
fracture.
fracture, there's no dislocation. That's
Yeah.
what we're looking for. Excellent. All right. Okay. So look, laboratory tests are fine. Troponin is 8, creatinine a little bit dry, potassium's okay, sodium's okay, platelets, white cell count, hemoglobin's okay. Imaging and ECGs you've just seen. Urine was normal. So in terms of differentials, what your differentials were, remember we were thinking about that. Now I'm just going to talk about tools. You remember the slide that I was sharing initially? I was saying that we need to do tools. Remember that one? This one? I was saying tools. So tools are very important. In
Yes.
hospital, we're giving more and more, tools assisted or pathway assisted. So there's some tools which are really good if you mix it with your clinical assessment. And this is one of those rules, Canadian syncope rules. This is the same, this is the same set of physicians who've done, Canadian C-spine rules and all that. So good rules are coming from that. So basically, Canadian syncope rule is in terms of the risk of estimated. So what is Canadian syncope rule trying to achieve? It is trying to calculate based on the number of parameters. It is trying to calculate the incidence of serious adverse event in the future. And is it very low, low, medium, high, or very high likelihood of having that incident based on the total score? So does the patient have vasovagal symptoms, predisposition to vasovagal? Well, not really, because she does not suffer from any vasovagal syncope. Has she got any known heart disease? Not really. Blood pressure low or very high? No. Elevated troponin? No. Abnormal QRS-QT duration or QRS duration? No. Vasovagal syncope takes a score less than 2, and cardiac syncope 2. So she does not really fit up any of this. So if I was to score that, even with a conservative estimate, I would say that she's probably 1. Would you agree with that? Oh, 0, sorry. Would you agree with that?
Yes.
Yeah.
So in terms of her estimated risk of serious event is 1.9, which is low. All right. So that means that she is very unlikely to suffer a serious incident. So that helps. So what would your management be now?
First of all, I'll explain the whole situation to her, what
Yep.
has been, what
Going
we
on. Yeah.
have done,
Yeah. Yep.
and what the imaging shows.
Very good.
Then I'll explain. Then I'll explain about. Look, you don't have any serious implications. It's
Mm-hmm.
just minor bruises you're having. For
Mm-hmm.
that, I can only advise you some conservative management. You can
Very
take
good.
some painkillers for that. You can
Mm-hmm.
also use some hot packs on your injuries if it's hurting you.
Mm-hmm.
And I'll call my
Hot packs
seniors.
or cold packs?
Yeah, cold packs.
Okay.
And I'll call my senior who will come and have a review. And
Mm-hmm.
if we don't find anything, we'll discharge you most likely.
Mm-hmm.
And on your discharge, I will give a referral letter to your GP who will
Mm-hmm.
review you regularly in her care, in
Yep.
his or her care. What I'm concerned about is your arthritis.
Yep.
So I'll also give you a letter to follow up with your specialist regarding osteoarthritis, and I'll give you a letter for occupational therapist who will
Mm-hmm.
come and have a look at the home.
Mm-hmm.
And because you tripped, so they'll see what are the hazards there, and they will help you manage that accordingly.
Very good. Excellent. Excellent. And I've got very little to add on, which I've got on my list, but I'll organize that. So you'd be surprised at how many doctors have got the same ideas. Obviously, everybody's got the same idea. It's mainly the organization which comes out and make it sound a bit more polished. But you're right in terms of the highlighted priorities in terms of communication. We really need to spell out the management. Just be very clear on that whenever we're
Mhm.
making a management plan, you need to explain the management plan to your colleague, doctor, or a patient as if you're explaining the plan to a 5-year-old. Does it make sense?
Yes.
And if you keep that concept in your mind that I'm really explaining it to a 5-year-old, you'll never go wrong. So down to the very basic in a simple layman's term. So analgesia, as you said, I'll give you some paracetamol. I'll give you something more strong for the painkillers, endone, to get on top of the pain. All right. We'll apply some ice packs. That's good. Now, one thing that we do in the hospital is we get aged care service in the emergency department to assist the mobility of the patient again. Now, this is a patient who's just had a fall. And you know what they first ask me? Have you given her some painkillers? Because if you've given some painkillers, it would be easy to assess her. Otherwise, it'll be very difficult. She'll still be in a lot of pain.
In pain, yes.
So use this term, asset team, emergency aged care service and emergency team. This is the local system. This is the local thing that we do. Now, after the asset team clears her, so it's not a unanimous decision that you're sending her home. Yes, you think that she's safe to go home, but you want asset. And what else asset do? Asset got a complete access to the physiotherapy and all the things that you think saying, physiotherapy, occupational therapy. They can refer the patient to outreach geriatric support, which would be geriatric consultant. Plus, they can also refer the patient to back to the hospital if they do a well-being call in the next 24 hours and the patient is not really pulling through. So the whole idea behind this team is to enable patient to live independently after having a fall or an injury at home. Does it make sense? Perfect.
Yes. Yes, it is.
So home after communication, and once the asset clears, what I tend to do is I call the family, which would be son or a relative, that look, this patient has had a fall. We've done the X-ray, we've done the assessment. Luckily, there's not any serious injury in terms of fracture. The pain is actually now well managed. The special care nursing team from the aged care service has seen her, and they're going to keep a follow up by the phone call, and they'll refer her to an outpatient occupational and physiotherapy. Is that okay with you? Would you be able to keep? Now, asset normally talk to the relatives as well because they are very holistic. So just by saying asset team, you're ticking off all the boxes in just one word. All right. But as a second layer, as I said, we are really explaining the management plan to a 5-year-old. It is often a good practice to go and call the relatives as well, because they may have some other reservation which asset might not have picked it up. All right, asset follow-up and then GP follow-up. And you're right, elderly falls clinic in terms of falls prevention approach. And Dr. Maha Parvez Iqbal has said pain relief prevention approach, which is just brilliant. Any questions from that point of view? It is really very simple, but you can see that how easy it is to make it a bit more polished by an organization of your thought process. These are all the cases that I see on daily basis. Any questions from that point of view?
Sir, why are we checking for UTI in this case?
So basically, any patient who comes in with a fall, elderly patient in particular, they could have an asymptomatic UTI. And UTI in elderly population makes them prone to so many things. That makes them prone to delirium, that makes them prone to further infection, that makes them prone to confusion. And all of these could be a contributory factors to fall. So whenever I try to admit a geriatric patient with even a heart attack, they say, "Oh, have you done a urine?" I say, "Yes, I've done the urine. It's okay." So always remember urine in elderly patients. And I was reading a book about elderly patients and their assessment. Often a urinary tract infection would exacerbate a chronic problem. So if they've got dementia, they would be more demented. If they've got Parkinson's with a UTI, they'll get more symptoms of rigidity. So always think of UTI as a catalyst of an exacerbation of their current problems. Okay. All right. Who is up for the next case? Next case is very easy. My personal favorite. Anyone? There's so many of you. There are like 36 of you here. Who would like to jump in? Anyone? It'll be fun. Come on. Dr. Kekasham, would you like to have a crack at this course, at this case? It's a pediatric case. And this is a good time. There's no really any restriction to not do that. Dr. Tariq, would you like to have a go at this case?
Yes, I can try.
Let's go.
Just give me a second. So 7-month-old Ryan has been brought to a small regional hospital by his mother, Emma, who is very concerned about Ryan's breathing. He has been unwell with a cough and runny nose for 2 days. His coughing is worse today and seems to be having a noisy breathing. Ryan is also off his food for the past 24 hours. COVID rapid antigen test is negative. Vitals, heart rate 130 per minute. Respiratory rate 54, set 90 saturation, temperature 38.1, task history, examination, investigations, management.
Yep. So we're going to be doing exactly the same thing, Dr. Tariq. Same 5 questions, 5 examination, 1 working, investigations, management, disposition. You happy with that?
Yeah.
Perfect. Let's go.
So for key questions in history,
Yep.
I will make sure the patient is, first of all, hemodynamic stable.
Yep.
Quickly go through DRS ABCD protocol. And
so you'd like to know the history, the questions, like you want to be asking the question to the parents, like, so what kind of questions would you ask the parents?
So since, how long it has been going.
Yep. So he's been unwell for about 2 days now, doctor. He's
2 days now.
Sick. Yeah, I started off with runny nose, and now he seems to be coughing. Coughing seems to be getting worse.
Yep. So tell me, more about the cough. Is it is it the cough and vomiting? Is it barking cough?
No, not really. It's just cough mostly at night,
Yeah.
and sometimes during the day as well. Today he's been coughing more, and he seems to be making noise during breathing.
Okay. Is there any associated symptoms like?
Look, he looks very tired. He's just a very happy child. He seems to be running around, but now he looks so tired. He's not really interested in his feeds. He's not really had his bottle of milk. Just not himself, doctor. And we took a temperature, and he was, febrile to 38.
I can understand it's quite concern for you, and but you're in safe hands. We'll make sure that he's okay, and we'll find out what is going on with him. Just bear with me. A couple of more questions. Any any associated any vomiting,
No
any
vomiting, doctor. No.
yep, any how is the pee and poo,
Look,
any
I've noticed that he's not been passing urine as much since yesterday because he's
Mhm.
actually not eating and drinking all that well. So yeah, he's not also passed stools for the 24 hours. So he's actually down on his outputs.
all right. Apart from that, is there any rash? Have you noticed any rash?
No rash, doctor. No,
Rash?
no.
Okay, cool. Um, and any issues with the birth? How was the birth? And
Birth was fine. Full
um,
term, normal delivery.
yeah,
Yeah, yeah.
is he up to date with the immunization?
He is. He is.
Yep.
Yes.
Okay. Any concern regarding the growth and
No,
development? No.
he's
Okay.
been
Yeah. Yeah.
fine. He's been,
Yeah.
uh, achieving all the milestones. I took him to his GP check last week, and we were quite happy with his progress
Yeah.
so far.
So quickly, uh, because the saturation is on lower side, but it looks like uh, it can be infection most
Mhm.
likely. Uh, so we need to stabilize first.
Yep, yep.
Start the
So that's very good. I mean, you've asked most of the questions which I had in my list. So let's just go through those questions. Okay. So I had like, when you're seeing a pediatric patient, whether in practice or whether in like an exam, just go through the chronology of symptoms. What was the first thing which came on? Was it like cough? Was it runny nose? Because most of the pediatric infection, like respiratory tract infection, start off with the upper respiratory tract symptoms. So get the symptoms chronology. Um, then symptom severity is very important. Like, has he been having, because that is really going to tell you whether you need to admit this patient or you need to send the patient. I mean, obviously, it looks like that he's got SATs of 90%, temperature of 38.1. He's not going to be going home. But obviously, in terms of any immediate action, like has he had apneic spells? Has he got cyanosis? That is important. And do you know why? Why is this important to have cyanosis and apneic spells to be accounted for?
um, the signs of respiratory distress, and it could be
Yeah,
yes.
yeah. Especially, it could be especially true in terms of bronch. Some of the bronchs, RSV bronchs, can cause apnea and cyanosis as well. And some of the kids are more vulnerable to bronchiolitis in terms of apneas and cyanosis. When I was working as a pediatric registrar at St. George Hospital, we had quite a few patients in that age bracket who would have central and peripheral cyanosis, who would have apneic episodes, and some of them really bradycardic, and that was my trigger to have them shipped across to neonatal or pediatric ICU to Sydney Children's Hospital. All right, feeding, you touch based on, that's very good. Prematurity, you just based on, that is very important because some of the neonates who are born premature, they may have like transient tachypnea of newborn, they may have hyaline membrane disease, they may have, lungs which are more prone to infection. So it's always good to check on that. And immunization history, sick contacts, and childcare is also important for any droplet transmission, for any GI illnesses. So, all right, okay. Now, in terms of the exams, what would you like to do? I think I've got all the exams here anyway. But what are the exams that you'd like to approach this child with? What are the 5 key exams you'd like to do, Dr. Tariq?
So from general appearance, I will look for, any signs of respiratory
Very
distress,
good. Yep.
like a nasal flaring, tracheal tug, any using of accessory muscles.
Excellent. Yeah.
Um, and other than that, any pallor, any cyanosis,
Yep.
any rash.
Yep.
Uh, After that, quickly assess the vitals,
Perfect.
um, you know, and cardiovascular examination, respiratory
Mhm.
examination, and quickly assess the abdomen, and just head to toe quickly. Yeah.
Perfect. So signs of respiratory distress, take vitals 3 times when the patient arrive. If you've given any treatment, then midway point, and then before, if the patient is going home, then you need to do the repeat set of OBS. So more OBS. In fact, there was an inquiry in patient deterioration in pediatric population. And one of the suggestion from inquiry was at least have 3 set of OBS, one on arrival, one midpoint, and one before the patients are actually went discharged either to the ward or they are admitted into the hospital. Okay. So, or sent home, sorry. So that is, so what's your working diagnosis, Dr. Tariq?
It could be bronchiolitis,
Very good.
most likely. It could be viral upper respiratory tract infection.
Very good.
After that, I mean, croup cannot be. I mean, it's least
Unlikely.
likely, least
Yeah.
likely.
Yeah.
But yeah, most likely it's bronchiolitis and viral. Yeah.
Yeah. So basically, whenever you say bronchiolitis, remember the natural history of bronch. They tend to get worse on day two. So day two is the worst day. There are a lot of secretions, there are a lot of mucus. They tend to clog up all the airways. And yes, so day two bronchiolitis. Whenever you start off by saying, look, I've got a patient who I need to admit with day two bronch, everybody will be on the same page. Day two bronch means moderate to severe respiratory distress. Day two bronch means they're going to get worse over day three, day four, and then they'll start to improve. So day two is a very, very bad timing for a bronch kid. While lower respiratory tract infection, you've talked about pneumonia as the other differential. Cardiac failure, unfortunately, some young kids could present with fever, with infective prodromes, but may have a cardiac failure. All right. And what is the other more important differential here, as we would say?
Foreign body.
Very good. Foreign body inhalation, neglect, or abuse is also an important thing to consider. So always have a habit of having one differential, one working diagnosis, and three or four differentials. Now, investigation wise, anybody, Dr. Tariq, what do you think about the X-ray, or anybody who can make a comment on the X-ray? So whenever you're looking at the X-ray from the pediatric point of view, make sure that trachea is midline, which it is. Make sure the heart is not enlarged, which doesn't, because that might be pointing out to whether he's got underlying cyanotic or non-cyanotic congenital heart disease with Eisenmenger syndrome, with LVF and what have you. Looks like a normal caliber. If there's any dense collapse or consolidation, any of the zones of the lungs on the right or the left side, doesn't look like it. There's no subdiaphragmatic air. There's no mediastinal air. So it looks like a normal chest X-ray. Then again, you could have very, very sick child, like this is actually quite a sick child, but have a normal X-ray. And that's what we find in pediatric population. You could have normal bloods, normal X-rays, normal investigation, but the child would still look very sick. All right, so what investigations are you going to do?
We're gonna do
bedside
bedside
radiology.
first,
Yeah.
urine
Very good.
urine, and check the random blood sugar.
Very
And
because
after
he's
that,
not eating, actually, that's a very good point. Yes.
and after that, the routine full blood examination, urea electrolyte, creatine, and to septic screening. Septic screening, just to touch base with that. And yeah, and chest X-ray.
Okay, good. So I'll give you one practical tip here. Okay. So in pediatric population, don't jump in to do, blood test. Like sometimes, they could be febrile, they look flat, they look like they've got severe respiratory distress. You give them some Panadol, your oxygen, and they look like 100% better. So have a stepwise approach. So instead of doing like bloods immediately, you can put like an local anesthetic cream on their hands to get them ready for a blood test if you need to do that. So bedside, you're right, cardiac and oxygen monitoring, UA, blood sugar. Laboratory tests we can do. I'd like to hold and review them again. Imaging, X-ray, because look, you've already got your diagnosis. It's a day 2 bronchiolitis. And in terms of bronchiolitis, the blood tests are not going to show you anything, because most of the bronchiolitis are really viral infections. And if you are looking at the X-ray, it does not really show any pneumonia either. However, there is one test that you would do, which is actually somewhat important. Any clues there? So we called it nasopharyngeal aspirate. So nasopharyngeal aspirate is good from the point of view because it can pick up the viruses. Not that it really matters all that much, because some of the viruses have got a natural history of causing very rapid deterioration. RSV bronch are very notoriously problematic. So, and plus the other use I find by doing the nasopharyngeal aspirate, it helps with the suctioning. So in terms of management, also this is the criteria for the bronch patient requiring admission. So again, the tools that we were talking about, Dr. Tariq, Do you look at this tool? So this is the admission criteria in most New South Wales hospital. His
Yep.
respiratory rate is 54. He's got an evidence of increased worker burden both with external costal, subcostal recession. Oxygen saturation is 90% on room air. He's not feeding well. He's obviously from, if you remember the scenario, he's from a regional town and coming to a small hospital. So he's not really in a safe environment. He's not got any prematurity, neonatal or lung, heart disease or immune deficiency, but other parameters are smack bang there. So this patient, are you going to send him home or admit him?
We'll admit him. All the 6 signs.
Absolutely, yeah.
Yep.
So the 6 signs are there. So in terms of management, how would you manage this?
So we'll put the IV line. Then we'll
also think about when you're thinking of IV line, what are the other parameters of hydrating a child, like a 7-monther? So say, for instance, it is very difficult to cannulate this child. You miss a few times. What
nasogastric?
Very good. So think about the
NG
hydration. NG tube is much better and it's more adapted here. We can still try for the oral if the child is interested. If not oral, NG tube. And if that is also failing, then IV hydration. Now the child is febrile and hypoxic. What else are you going to do?
So we'll start the oxygen and give Panadol.
Very good. Excellent. Excellent. Now, there's one thing that I tend to do in all the bronchs, and I would encourage you to do as well. Anybody? We just talked about that briefly.
Humidifier, basically.
Well, I mean, oxygen is via the humidified, but there's one thing else that you can do.
Vitals.
Vitals we've checked, but there's one thing in terms of management that we can do. We were talking about
minimal handling of the patient.
No. No, we were talking about that last step, that I would do that.
Talking to the parents.
That is also very important. In fact, that is probably more important, but there's one more thing I'd like to do early on.
Suctioning and physiotherapy of the chest.
Very good. So nasal suctioning, because day 2 bronch, why is it bad? There's a lot of mucus secretion. All of that mucus is causing the back of the throat. It's dripping down into the lungs and it's causing all that deterioration. So that is very important. All right. Okay. Excellent. Transfer to pediatric facility. This patient needs a transfer. So we need now to be talking to the pediatric registrar in accepting hospital and inform the parents about the plan. So if I was to ask this patient to be referred to a pediatric registrar, how would you do that? Dr. Tariq, can you make a referral?
Yes. So hello, my name is Tariq. I'm one of the junior medical officer calling.
I'll give you a roadmap so you can follow this. Right, there you go.
So hello, I'm Tariq, one of the doctors. I'm Gmo calling from emergency department. And I have got the patient, Lisa, who is 7 months old, presented with shortness of breath and noisy breathing and cough history. And based on the situation, she, so we, based on the assessment, actually, we found out that on examination, she is having, she's pulse rate is this.
I'll tell you one thing. So instead of you've got the introduction, I've got I'm so and so calling from this hospital. This is a patient, and you can start by situation by giving your diagnosis. That is as simple as that. So you can say it's a day 2 bronch with moderate to severe respiratory distress and hypoxia. That immediately tells you concern, severity of the problem, and the registrar over the phone on the other end say, yes, I take it. All right. So articulate your concern. So your concern is the child is requiring oxygen.
Yeah.
And he's got signs of moderate to severe respiratory distress, right?
Yeah.
Perfect. All right. In terms of background, is there anything medical or surgical or social issue?
So, so what we have done is we have just started,
No, I'm just saying that in terms of, we're still following ISBAR method. So in terms of background, is there anything else which is relevant in terms of medical, surgical, and social history?
The patient is from regional
Very good, very good.
place,
Yeah.
and
So he's rural or remotely placed.
yeah,
That again is a very concerning signs. And then you can talk about brief cyanosis or treatment. So you've given him a unified oxygen, you've
yeah.
given some Panadol, you NG rehydrating him, and then you update them. So go on and tell your assessment.
So based on the current vital signs, and so I will tell them this is a
Yeah, the
pulse rate,
oxygen's improved,
oxygen
respiratory distress
improved.
has come out. Yeah,
Yep, and what we have done is so uh, we have started the we have put the NG tube and started the fluids because the patient was dehydrated. We started the oxygen and given the Panadol as well, and we have informed the patient's parents about the and now patient needs further admissions because of the child is sick, not eating well, not feeding well, not drinking well, and looking lethargic and drowsy, and the day 2 bronchiolitis, so needs further inpatient assessment and management. Yeah.
perfect, perfect. So look, this is a perfect example. So always follow an is bar method or referral. Introduce yourself, patient, and start whenever you're given the situation, your diagnosis, your working diagnosis. Day 2 bronch. Other concern is hypoxia, febrile, could be an early septic patient. The chest X-ray, however, looks normal. Background, it looks the patient is in moderate severity, moderate to severe respiratory distress. Plus, he socially lives in an area which is rural or remote. And this is what I've done in terms of improving his condition. And this is how he's responded or not responded. And I've told the parents that we need to have him shipped across to the tertiary referral centers to have it treated. Easy, right? So what you've done right now is actually solve two cases exactly as we would solve them whilst working in the hospital. There's no rocket science behind it. And I would argue that if you stick to the same schema in terms of key questions and key examination and key investigation and management points, you'll save time and you will be able to tick most of the boxes which are relevant both practically and from the examination point of view. Anybody wants to do the third case, which is the last case, and then we'll move on? It's a really important case. I like that one as well. Anyone? Dr. Sarika, would you like to do a case with me? Dr. Sadaf, would you like to go through? Dr. Kohila?
Yes, I can volunteer.
Okay, excellent. Thank you, Dr. Kohila. So this is your case. You can go and read it.
Okay, so we have a 24-year-old Nicole Banner has presented to GP to get an X-ray of her right hand. She says that she had a fall 2 days ago and now left hand is swollen and bruised and very painful. She also seems to have facial bruising and right eye swelling. She is not very forthcoming with information and just wants an X-ray and go home to look after her 4 young children. Vitals are given: blood pressure 110/70, heart rate 89 beats per minute, saturation 98%,
Mhm.
RA afebrile.
Yep. So no fevers.
Yeah, okay. So for tasks of focus, history and examination, plan appropriate investigation, management and disposition.
Perfect. You got the
Okay.
idea?
Yes.
Perfect, perfect. So again, the same thing, 5 key history questions, 5 key exam questions, working diagnosis and differentials, which in this case would be the number of injuries, and then what would your management and disposition decision be on clinical handover. You already have got a gist of the case, right? By reading
Yes.
about the case, what are you worried about?
Yes. Actually, we have to assess her from head to toe. So
Yep.
I would like to start with the history.
Yep.
Hi, I'm Dr. Koila. I'm one of the medical officer working at the emergency department.
Oh, she's to
So
the GP. She's come to the GP.
okay, sorry. Yeah, I'm
That's okay.
okay. So I'm doctor at the GP clinic.
Yeah.
I would like to start by confirming your name and age.
Yeah.
Uh,
So my name is, I have actually forgotten her name. I think her name Tracy, maybe. Okay. My name is Tracy, doctor. And yeah, I've had a fall yesterday and hand's quite sore. Just want to get an X-ray done and, go. Just want to make sure it's not broken or something.
Okay, I'm sorry about that. So, like, I would like to ask, what happened exactly? Like, how did you have a fall? Did you fall like after following a syncope, like after falling an unconscious level, or were you like tripped and fall? What can you please explain me? What exactly happened?
Yeah, I don't really remember what happened. I think, yeah, it looks like I was sleeping on the bed and I may have slid and just fallen down on the floor.
Okay, so did you lose consciousness after falling?
No, no, I didn't.
Okay, so did you have headache?
No, I haven't got any
Okay.
headache.
Any vomiting?
No, not really. I haven't really vomited.
Okay. Do you have any abdominal pain? Any difficulty in breathing?
No, no, I'm okay from that point of view. I'm really quite okay, doctor. I just want to go home after getting the X-ray, if that's okay.
Yes, I can understand your concern. Like, because in my triage notes, I can see that you have 4 young children. So,
Yeah.
if you, because of this, we have to actually admit you, and we have to do the assessment head to toe, as we would like to order some investigations as well. So, if you want, I could address like a social worker to look after your children at home, if you don't mind.
Doctor, there's really not need for that. My partner is at work. He has to go to work, and I have to be at home. So yeah, I really don't have much. I would really like to go home. I can come back later if you like. What do you think
Okay,
I should?
so yeah, we can understand your concerns. So, we have the basic vital signs, and I would like to go with I would like to ask few more questions. Do you
Yeah.
have any other previous illness that you have been followed up for?
No, no, I'm quite okay actually. I haven't got any medical problems.
Okay, do you have any other surgical or any other allergies?
No, no, I'm actually quite good.
Okay, can I ask your last menstrual period?
Oh, it was 2 weeks ago.
2 weeks ago. Okay.
Yeah.
So I would like to also get some other history, like at home. How is your situation? How do you cope up with do you get enough partner support?
Oh, look, doctor, it's a very busy life. Got 4 young children. And 3 of my children are under the age of 5. One of them is 6-year-old. I'm a very busy mom, doctor, and often things don't go as planned smoothly these days because of COVID. None of them are going to school; they're all at home. My partner is, just found his new job, and because of COVID, our situation is not very good.
Okay.
um, so really, that's why I wanted to go home to look after the kids so he can go
Yes,
work.
yeah,
Yeah.
I can totally understand your concerns. So, do you think that is there any stresses in your life like that you can address? I can
Mm,
really understand you're under currently like looking after 4 kids and they're at home. So, do you feel like it's a like a stress to your life?
I don't know, doctor, what to say.
Okay.
It's really very difficult. A lot of stresses, and
Yes. Have
yeah.
you ever been threatened by your partner, or do you feel like anything? I'm sure. Before that, I would like to establish the confidentiality. It will be
Mhm.
whatever you say. It will be like between us.
Mhm.
So don't worry. Unless there is a threat to your life or anyone else. Like, have you ever been threatened by your partner or?
Well, actually, doctor, this injuries that I've had is because he hit me. He hit me yesterday, and it's not the first time he's hit me. He's hit me a few times, so I'm
Okay.
really worried for the well-being of my children as well because he shouts at them. He doesn't hit the kids, but sometimes he gets drunk and he gets frustrated and angry, and he can do anything. So
Yes,
yeah.
I can totally understand your situation. As it had been happening, for the like few times, and as it's not the first time, so probably I would like advise you to like get some support, or we can even refer you to some support groups. And actually I just want to inform you, but it's totally with your hands, and it's totally up to your decision, that because domestic violence is actually it's a reportable offense. So if you really want, you can actually inform the police, but it's actually totally up to your decision. But still we can provide you with all the support, and if you feel still threatened, we can even give you a voluntary admission to the hospital, so
Okay.
that like you can be away
Yeah.
from the threatened situation.
All right. Okay. Well, that's very good. Let's just go through. That's very good, actually. So, in terms of
Okay.
history, you established a few facts: past medical history,
Yes.
drug history, allergies, social history. You've gone through.
Yes.
What would you like to do now? So we've you've built rapport in all the confidential. You've got the history, injuries, time, and details. Been aware. You've understood that there are 4 vulnerable children at risk. She's told you there's a lot of alcohol involved, and he gets super angry, and he beats her, and
Yes.
it's a complex social situation where kids are at home. He
Yes.
is not been able to find work, and has just gotten himself a new job, and he's very he's very anxious about that new job.
Yes.
So what would be your key examination findings? This is the patient, so there you go.
Okay. So as her GCS and GCS is fine and vitals are stable. So from the head to toe, I would like to examine her. So the face, on appearance, I can see a right-sided facial bruise, and also there is a bruise on her left hand. So I would like to examine her. Start with her like pupils, whether they are bilaterally equal or
Yep,
like
the
equal.
pupils are fine. Yep.
Okay, and then I would like to look for any head injury signs, like any ENT bleeding, such as any battle signs behind the ear, or
Yeah, I mean, there's
any
some bruising around the right cheek,
right.
but not
Yes.
really. There's no bleeding from the ear, nose, and throat.
Okay, then I would like to start with the palpation. Like as there is a bruise, I would like to palpate it like after addressing, explaining her to the condition and giving an analgesic, because she may be in pain. So I would like to palpate for any maxillary fracture, and to do the facial nerve examination as well.
Yeah.
And would like to look for any like inferior orbital fracture, but
Very
as
good. Yep. Very
according
good.
to this, there are no signs of any exophthalmos, or even we have to assess by the supply but infraorbital nerve to check
Yep.
the
Very good.
sensation of the
Very good.
facial area. And also we would like to do a proper eye examination also, to check for the eye movements.
Yep.
And
So the eye
uh,
movements are not coordinated. She's getting diplomia on rightward gaze.
okay, so that means probably we can suspect a sixth nerve injury, and we will have to arrange. We have to complete the full eye examination and arrange ophthalmology referral.
Very good.
We would like to order, before that we would like to order for some investigations, like CT scan of the head,
Okay. Let's do that.
and
So you've done the primary survey and
yes.
secondary survey. You've got the neurological and eye exam, and I've told you their lack of coordination findings. The left hand, any comment on that?
Yeah, so left hand, I can see bruising. So I would like to palpate all the joints, and
Yep.
also I would suspect any fractures
Yep.
probably. So we'd like to order for an X-ray imaging of the left hand AP and lateral view.
Perfect.
And I would like to assess for the finger movements and
Yep.
sensory, and check the capillary refill time to exclude the distal neurovascular status of the fractured hand.
Perfect. And you'd also like to look for the old or missed injuries, because obviously this is
Yes.
a lady who has had issues with domestic abuse, violence
Yes.
from an intimate partner, and you'd like to check for any other hidden or occult injuries, because there could be some serious injuries in there.
Yes.
So in terms of your work and diagnosis, doctor, what do you think is going on in here, and what are you concerned about?
So my most likely the injuries are sustained to like probably as she confessed it's like a domestic violence,
Yep.
and that would be my first diagnosis. But I would like to also look into other probabilities, such as it could be like a simple trip and fall, as she told in the beginning, and she would have injured probably like a maxillary fracture or even zygomatic bone fracture, and also left-sided metacarpal bones fracture and
Fracture.
any
Perfect.
fractures.
So yes,
And
when she's given you the history of non-accidental, that's your concern. Head injury, you said. Orbital
yes,
floor fracture, you've also said, and the right metacarpal injury, you've said. So in
yes.
terms of investigation, we've done the investigations in terms of bedside, laboratory, and this is the X-ray. You can make a comment on that X-ray of the hand. Can you see
Uh,
this?
yes, I can see it. So first, I would like to comment on the X-ray. This is a left-sided hand X-ray showing the anterior posterior view, and there is a mid shaft of the fourth and fifth. Actually, the proximal interphalangeal
No, no,
joints
no, no,
have
no.
been affected.
Not proximal.
Metacarpal.
Oh, sorry,
Metacarpal.
metacarpal. Sorry,
Metacarpal.
sorry. Yeah, metacarpal joints have been fractured,
Yeah.
and we would like to ask her to rest and apply ice, and also put a splint, and elevate the arm, and then we will refer her to the orthopedic
Or hand surgeon,
surgeon.
yeah.
Yeah, to probably
So, and
fix
this is
K
the CT
wires.
scan.
The CT scan shows right-sided orbital flow fracture, but there
Yep.
is like and also the probably the zygomatic arc bone fracture,
Yeah. Could be, yeah,
and
but we haven't got a good view, but there could be, yes.
yes, but there is no like obvious uh, protrusion of the contents into the maxillary sinus, and the rest of the like rest of the bones look almost normal.
Yeah, that's
I
fine.
think
So
yes,
basically,
yeah,
infraorbital, inferior orbital floor fracture. That's why she had diplopia in the movement of the eyes. This can complicate to enophthalmos because the herniation
yes,
of the content in the eyes push
yeah,
the inwards, and that's a long time cosmetic disfigurement. This is
yes,
called a boxer fracture when you punch the wall. So she may
okay,
have punched the wall in terms of, punching the wall out of frustration, or she may have punched the wall when she was acting in self-defense. Who knows? So this is the injuries. These are the injuries. So in terms of investigation, her investigations are largely okay in terms of hemoglobin white cell count. Imaging you've seen, urine dipstick's normal. Reporting is one thing I'd like to highlight. Reporting is mandatory. So any
yes.
domestic violence, you cannot leave it to the patient, and especially if the kids are involved, you need to report it. Who do you to report to? So you're in a GP practice. You've got a patient.
Initially, yeah, we have to report to the Child Protection Authority because children are at the
Yeah,
highest threat, and then
vulnerable.
only
Yeah,
we have to inform her about the domestic violence. Also, initially,
perfect.
Child Protection Authority.
Excellent. So let's just manage this systemically. In terms of this patient, what does she need?
uh, we would initially refer her to counseling, like initially Child Protection Authority
Yep.
comes first, and
Yep.
then we can address the patient regarding the domestic violence, and we have to make a full report. But I think the patient's decision makes a final decision whether it's her up to her whether she wants to report it or not.
No, no,
Um,
no. This is reported. This
report.
is not
Okay,
up to
sorry.
her.
Yeah,
Yeah, this is
right.
because
Okay, good. Yes,
next time she may not come. She may be dead.
yes,
So
exactly.
this
Yes,
is something that this is, in fact, if you say that you're going to leave it to the patient, she will say
right.
that I want to go home, and then
Okay.
most of the time
Yes,
she will. So basically, I was thinking more in terms of that specific thing. So analgesia you need to give the patient, you need to plaster the patient's hands and what have you. She's got
yes,
an orbital floor fracture, and what would the
yes.
management would be the maxillofacial referral, and from the hands point of view, orthopedics or plastic referral. Now you're going to report it to the social worker, and if there's no social worker there in your area, and then police even,
I
um,
see.
and then obviously because of the injuries of the hand and orbital floor fracture with the compromise, she may require an admission.
Yes.
And if she requires an admission, then the kids are vulnerable. So you need to have like a social worker there. Um, she may need, if she lives with a partner who is a perpetrator, then she may need like a women refuge and obviously the child protection from that point of view. Does it make sense?
Yes.
All right.
Thank you.
Not a problem. That was very good, actually. That was good. You picked out most of the points. How about we take 2 minute break here, and then we'll start off with the jobs and all that kind of information. Is that okay? Perfect.
Yes,
Perfect.
sure. Yes.
All right, we're back. Let's start off again. So, in terms of medical jobs, we're going to talk about. Oh, hang on. There's a question there. The guidelines only state that partner domestic violence will document the incident injuries, provide the patient with all resources, offer help, report partner violence only with the consent that
Why
he can
settings
offer.
like
So
that
we
lock and stuff
should.
say,
And
and things like we want face to face.
all right. So it also depends upon the well-being of the patient. In our hospital, there's certainly a policy that if you are worried about the patient well-being, that is the nature of the injuries is severe enough to compromise her well-being, then you have to report it to the social worker. And then the social worker can have a chat to the family, can have a chat to the patient, and can have a chat to the police in terms of legal framework. So I refer all my patients with domestic violence to at least social worker. So hopefully that makes sense, because it depends upon the severity of injuries. If you've got a fracture, if you've got a head injury, if you've got a brain bleed, you can't let that patient back home. You have to refer the patient to at least a social worker who can make adequate inquiries on your behalf. In hospitals, we don't have often enough time to go through the minutiae of the legality framework, but we do refer all our domestic violence patients to the social worker. Hopefully makes sense. Yeah, so even if the patient was reluctant, you can talk, you don't have to chat. So even if the patient is reluctant, initially most of the patients are reluctant, but in practical way, once with a good rapport. Now this patient was initially reluctant to share the information, but after that, she opened up saying the partner is very abusive and she's more worried about her well-being. So she's actually raising a concern that she is worried about the well-being of herself and her children because he shouts at children. So you have to take things on case by case basis. There's been quite a few complaints. In fact, there was one complaint in particular in our hospital in which the patient, who was a mental health patient, was discharged home thinking that she might be mentally acutely psychotic. She was raising some concern. There was some serious injuries, and we brought her in for serious injuries from the follow-up point of view. And then there were some more injuries, like really nasty injuries. So um, now the local policies are more in, if you're worried about the patient, if the patient has raised a concern about her well-being, even though she might be initially reluctant, then at least involve the social worker. There's no harm involving a social worker. Absolutely, you must inform the social worker. All right. So, in terms of job, the process of getting a job is quite straightforward, right? You have to do your AMC 1, you have to do your AMC clinical. In between the main time, you have to do OAT and IELTS. Then comes the recency of practice, clinical observership, courses, and CPD. And then you do applications, interview, accept the offer, and start applying for registration, which could be limited and provisional based on your AMC 1 and 2 status. You get an orientation and start the job. That's the roadmap essentially, but it does not go exactly as I've mentioned in these 5 points. You may pass AMC 1 and you may get an interview call. You may actually have passed AMC clinical and you may not get a job offer or any shortlisting for a number of duration of time. So there are few things which are not according to the trajectory that we often predict, and it is frustrating. But then again, it is important to do these things regardless of what the offer is, because we need to improve our credentials. We need to make sure that we are, when we are applying for jobs, are continuously improving ourselves. So in terms of lots of participants who have got AMC 1, they're the ones who had very few career gaps with no recent requirement, obviously. They had a good experience in terms of emergency pediatrics. Some of them had ICU and research experience, general surgery experience. So it all matters that what experience have you got in your previous professional life. If you got a good experience, even AMC 1, with no recency requirement, you'd get shortlisted. And I've seen plenty of that. Unfortunately, not many people come forward when they've got a job offer. The only people that you hear about are the ones who have not got a job offer. But the additional surplus that I've seen consistently in most of these people is that they have been engaged in some other things. They've not been sitting idle. You need to be in the hospital environment or at least some sort of CPD activity to be getting shortlisted. Remember, the recency requirement are different from board as compared to the hospital. And we'll talk about that, like what is the recency expectation from the hospital point of view. You must also have, or they must actually, they had active registration in their home country, wherever they come from. And most of the people who have been able to get jobs in the first few shortlisting had excellent understanding of the interview process, the medical application process, and their communication skills were exemplary, at least in my experience. Now, the people who've got AMC clinical, they have had a gap and they fulfilled the recency requirement. They've had hospital clinical experience, ED, pediatrics, ICU, medicine, general surgery, similar to that. Again, CPD activities and active registration and good communication skills. Now, what is recency? What is recency is that, in terms of 4 weeks full-time equivalent to the registration period, which is total of 152 hours, 12 weeks of full-time, and in terms of 3 consecutive registration periods, which is total of 456 hours. So in terms of recency, your requirements should be met, and it varies. It varies from different individuals based on your clinical experience, whether that clinical experience was limited to like a hospital or a tertiary level hospital or a basic hospital or a rural hospital. It needs to be an amalgamate of that. And if you've actually got an experience which is far lagging behind or beyond 3 years, you need to submit a re-entry plan. All right. Yes, I know there are struggling people with long gaps, unfortunately, especially female doctors with moms. But then again, look, I've had success stories, or I've heard success stories from those very same moms getting jobs in 8 years' time. So don't assume, or don't look at other people's and automatically assume that this is the same thing which is going to happen to you. All right. You need to make sure that you have to have a positive vibe. Plus, during that positivity, you need to be constantly improving yourself. Trust me, some of the CVs that I've seen, some of the application form responses that I've seen, they are abysmal, they're abhorrent. So with something which does not make sense. So we need to realize that we need to be constantly improving. I can understand there could be domestic issues. You're looking after your young families. I did same when I was transitioning between different countries. But the main catch here, in between the people who tend to get the job with long gaps, are the people who are improving themselves, who are improving their application process, who are improving the CPD, who are trying to expose themselves to some sort of medical work experience. We know about level of supervision in terms of level 1 practice and level 2 practice. This is more related to the hospital provisions, that if you, most of the IMGs go into level 1 practice. Um, no practice in the last 24 months, previous experience of less than 2 years, and a supervised position for minimum 6 months before they proceed on to level 2 practice. And level 2 is the more senior people who are applying for SRMO jobs and above, and they have got a gap of more than um, they've worked full time in the last 24 months and more than 3 years of experience previously. So let's just quickly go through the medical applications and what are the common issues, or what are the types of questions that they normally ask, and how can we improve, because I think we've got to focus on one thing at a time. You need to get shortlisted first. Okay, if you get shortlisted, that is half of the problem solved. And then the interview process, which is another half of the problem. All right, so I think we need to look into that. So if you have got qualifications, skills, clinical governance, and quality assurance, that's where the questions are coming from. So if you look at the application questions, they're exactly based on the qualification, skills, and clinical governance. All right. And how to answer those questions is even more important. This is the most relevant thing that we must know, because these are the things which are going to get shortlisted. All right. So, for example, you need to have a job description understanding. Now, when I say job description, you need to understand that job description is just not there for you to make aware that this is what the job is like. It is for you to draw parallels to your clinical experience in the past, whether you've worked as an intern, whether you've worked as a resident, or whether you worked as a registrar. You must find similarities between the job description that you're applying and your previous experience. Plus, you need to also have an understanding of what the hospital is like that you're applying for a job. That is also very important. That hospital might be a tertiary hospital. That hospital might be a rural hospital in which there's a lot of reliance on more skill mix, and they need a lot of procedural skills in their JMOs. Or they might be, a hospital which is specialized in a certain area or certain field of medicine. You also need to understand that responsibilities of JMOs are quite similar across the board, whether you know it's a tertiary level hospital or a district level hospital. The JMOs are primarily responsible for taking the history, doing the examination, sending the bloods, admitting the patient, referring the patients. So these are the responsibilities that you must be putting there in the application in much more succinct way. I cannot emphasize that point enough, which not many people do that very adequately. All right, so now let's go. Your experience must be aligned with the job description. Okay, so for example, if you go through the job description, coordinating and documenting the admission, this is the actual job description actually. Coordinating and documenting the admission, which is a skill-based question. So remember, we were talking about that the questions are only going to come through the three main domains: qualification, skills, clinical governance, and quality assurance. All right. And so coordinating and documenting the admission, management and discharge planning the patient seen in admitted to their unit. So this is a job description from one of the hospitals for their RMO position. The day-to-day assessment of the management of patient in the unit, communicating with them and their families, communicating and coordinating with the team, arranging consultation, and all decision concerning patients in consultation with the immediate supervisor. Now, if I was to get a volunteer, something like, I think someone who's chatting me like direct messages, uh, Galaxy A71, would you like to tell me? Because I would really like to help you. And we've got lots of questions there. If you'd like to tell me what does this job description mean to you, maybe we'll be able to identify what is it all about and where were you lagging and how can we actually help you. Would you volunteer yourself? You don't have to tell me your name, but you can just tell me what do you understand by this job description. Not really. Okay. All right. Dr. Bushra, can I just ask you if you're there? What do you think my
Sorry, in terms of what? I didn't get the question properly. Sorry.
So basically, this is a job description for an RMO position. I presume that you're still looking for a job, Dr. Bushra.
Yes, I am.
Right. So this is a typical job description.
Yes.
And I've highlighted that job description is based on skills, governance, and quality assurance question. We have to understand each of the different components. Now, if we were to take an example that coordinating and documenting the admission,
Mhm.
which is a
Mm.
skill based question, what would your understanding be from that point of view?
Okay, coordinating and documenting the admission means like when I when the patient comes to me and how I assess the patient, like I took the history, like the things we have done, the focus history examination, and then I assessed on my working diagnosis that whether this patients require the admissions or not. But and then I think other thing the documenting is basically how I know how I know that the what documents need to be required to be filled and how the whole process goes on. So this is what the skill base is. If I have done previously in my workplace or anything, how the things have been done there, and we'll see how the things in the Australian system is. I think this is what it means.
Yeah, so basically, you are right. Some of the aspects that you've highlighted, Dr. Bushra, is absolutely spot on. But there's more to that question, what it sounds like. So coordinating and documenting the admission
Okay.
is to firstly identify the need for admission for a particular patient.
Mm-hmm. Yes.
Why do you want to admit the patient? Like, is there a reason to admit the patient because you want to treat the chest infection or
Mm.
pyelonephritis or a stroke? So that you've got a reason for an admission.
Yes.
Then for that reason, and that's a very important part, where do you think this patient can be safely admitted? So that's
Okay.
the so the emphasis is coordinating. It's
Mm-hmm.
not admitting, it's coordinating the admission. So that means, say for instance, you've got a patient with a stroke, you're working in a small hospital which does not have a stroke bed. So
Mm.
you're coordinating an admission of this patient into a stroke unit bed in a regional hospital. So
Yes.
that is part one. That's the coordinated. Then you come documenting the admission. That means that you have to talk to your own supervisor in that small regional hospital that, look, I've got a patient with a stroke who needs an admission for consideration of thrombolysis or, endovascular clot retrieval. And I've had a discussion with the neurology registrar in the aseptic tertiary hospital, and he's to be transferred lights and siren towards the other hospital. So that's the documentation of admission from the medical point of view. Then you
Mm.
have to get the nursing aspects of it, liaising with the nursing in charge. And there's one more thing, bed managers. So that is the other thing that you need to highlight, that this is the coordination of admission for a medical reason of a stroke. Stroke registrar have discussed the case with me and accepted the care in the stroke unit bed. We are going to have the patient transferred through the special ambulance with the paramedical staff. I've discussed the case over with my consultant so and so, and also I've discussed the case with the bed manager and the nursing in charge of both the hospitals, so the patient transfer can be coordinated seamlessly.
Okay.
That's one aspect of the point here. The other aspect is that you have to give a personal example. That, look, when I was working
Mhm.
in a hospital, for instance, from Pakistan, and we were working in a small rural hospital, district hospital, or even a tertiary hospital, and we needed to admit the patient into a specialty, that's how we would do it between a gastroenterology team, from a respiratory team, from a neurosurgical team, whatever it is. So always try to answer the question from the point of view of, skill base. What are they asking me? And then giving your personal narration that you have actually done that in the past, and you need to demonstrate that with your previous experience, that that's how you used to do. And because unfortunately they are a little bit biased when it comes to application shortlisting, they are expecting you to put the response based on the Australian health system. They don't care if you haven't got Australian health system. They would expect that after doing the AMC and after doing, your CPD activities, you should have a reasonable amount of understanding of how the system works. And this is how the coordination and documentation of admission would mean. Similarly, management and discharge planning of the patient seen in or admitted to the unit. Now, seemingly, it may sound like it's just about management of the condition and discharge
Hmm.
of the patient. But there is so much to it that I can write like at least half a paragraph on each of that. Management of the patient from an acute illness, management of the patient in the hospital, in the community, making sure the patient when is discharge planning. Discharge planning is a whole science. So if you've like we've done a case and you were helping with that case, elderly fall, right?
Yes, yes.
What was the discharge planning there? You made some
Discharge
very good
planning, yes.
point. Yeah,
Yeah, the discharge planning was to involve the first to tell the diagnosis and then the painkillers, the initial management of the patient, and then we have to involve the aged care assessment, the
very good.
aged care assessment team. So who
Exactly.
does most of the work, but we should know that what they are doing. Like you mentioned that they are very holistic, like they involve all, they cover most of the aspects. So that I have to mention, and also then involving the family is really very important
That's right.
to let them know if they have any concerns, and a follow up with the GP. So again, all the things you have mentioned with that case that we have to follow. Like again, I can understand what you are saying, that it's not just one aspect of the management, that okay, I'll do this and this, but you have to elaborate more on how we stepwise going
That's
on.
right. So that's exactly the point of our cases that we are doing
Yes.
in this orientation workshop. Because when you do these cases and when you're filling in the application forms, not only it tells you how to actually manage the patient, but
Hmm.
how to safely discharge them back
Yeah.
into the community with the help of the asset services, with the help of the outpatient occupational physio, GP
Yeah.
follow up, and orthopedics into a play. And then obviously telling the relative as if they are 5-year old, explaining everything to the patient and the relative. And
Hmm.
then the most important thing, what is the most important thing? Narrating with your personal example that, look, I have actually done
Yes.
this
Okay. Oh yeah.
and
Okay, I get
have
it.
done it repeatedly in surgery, medicine, pediatrics. That is what they love to hear. Look, you could write a very ideal and very, very good
Hmm.
response to any question, but if it does not give a personal narration, so they'll be looking at your CV. So this doctor has worked in general medicine, general surgery, in this hospital and that hospital. But when I'm asking a question about the discharge planning, none of that experience in medicine and surgery is reflecting on this question.
Yes.
So it's actually linking up your experience to the question at hand. Does it make sense?
Yes. Yes.
And that's actually where we fall short of our expectation in terms of getting shortlisted. We are not linking up adequately. First of all, we're not able to understand the question, and when we
Hmm.
do understand the question, we're not making the equivalent parallels. If you do that, trust me, the shortlisting will not be an issue. Once you get that balance right, you will get shortlisted. But we
Yes.
need to find those parallels. All right. Now, communicating and coordinating care with a team, arranging a consultation with other staff when appropriate, arranging discharge, liaising. Now, I can see in this clinical governance quality, I can answer this question with a perfect example that, look, I had a patient admitted with an acute pulmonary edema. The patient actually deteriorated in the ward. I had to call the med team or medical emergency team in the ward, initially stabilize the condition, inform my consultant, and manage that patient accordingly, and then updated the family. And because I have done that in the other hospital as well, back home in my country or back where I was, or I have actually seen it being done in my clinical observership, or I've actually talked about that in that medical literature. Such is my understanding. So it does not really matter. Like, you might be an intern and you might be oblivious to all these steps of governance and assurance, but you can draw parallels by some theoretical knowledge as well. So they can say that, look, this doctor is quite honest with us that even though she has not or he has not done that, but he knows the ins and out of the system.
Yeah, well, that's a very good point. Thank you so much for like bringing it
Absolutely.
on. Like we might not, because we might not have seen all the type of patients and we might
Absolutely.
have not seen everything, but yeah, that's a good example. Thank you so much.
And there could be so many different job description aspects, and you may not have done and all
Mhm.
decision concerning patient consultation, the immediate supervisor. And I'll give you a perfect example that I was working day before yesterday with a doctor in which we needed to decide the ceiling of care. And for that ceiling of care, you need to have the patient into confidence, the patient relative into confidence, highlight why you need to have the ceiling of care a certain level, and then document that in the notes so that everybody is aware of that. So we'll just do a little exercise, and I won't grill anybody on that. Basically, it's your understanding. Whenever you are answering a question, first of all, try to understand, as I've just highlighted, like, what is this question? Is it asking you to demonstrate a skill? Is it asking your knowledge about an aspect of governance or quality assurance, or is it based on your experience? And then answer it based on your experiences. Example is very important. If you've done that in the past, great. If you haven't, then you can even example it by that I have an understanding of this being done by someone else. I have got an understanding having read the policy on that. So again, you have to be smart about these responses. A typical response would be that, look, this is a question actually. This is an actual question in the medical application form. Demonstrate ability to work independently, escalates from urgent care, and seek help and supervise and communicate effectively within the teams. Um, would anybody like to go at this question? Like, what is this question about? How would they just give me like a framework? How would you like to answer this question? Anybody? Okay, Dr. Rahmat has got a suggestion, which is a very good suggestion. You need to answer the selection criteria by STAR method: situation, describe a work situation that you were faced; task, describe the task that you complete; action, describe the action that you took, complete the result. Dr. Rahmat, if you're there, would you like to, answer this question in particular? Do you think you can do that for us, please? You've done a very good point. You've raised a good point. Do you think you can do that? No. All right. I often find that
Maybe I can try, sir.
yeah,
Yeah.
yeah, good, good. I often find that this is like you've raised some very good point, and I think if you can demystify some of that for some of our colleagues, that would be really good. You there, Dr. Ahmed? I think we've lost you. Oh, I think we've lost Dr. Ahmed. Can you hear me, guys? Can you hear me? I'm not sure if I've lost the connection or
Yes,
what's happening.
we can hear
Okay.
you.
All right.
Mm.
Okay. Okay, I think he was saying that he wanted to do that, but all of a sudden he's gone off. Anybody who would like to have a crack at this question, like just as an exercise, as a group exercise, how would anybody? I mean, this is a question that you will be filling in this afternoon or tomorrow in your application forms. Why don't we just go through that as a collective exercise? Don't be shy. It's all for the mutual learning.
I can try, sir.
Okay, go for it.
So I have got the patient, maybe the acute chest pain, and I was working as a ED JMO. So
Mhm.
what I did is I quickly assess the patient, and then I'll find out. I found out that the patient is having acute myocardial infarction. So
Mhm.
we initially quickly assessed and managed the patient, give the the treatment,
Mhm.
immediate treatment. After that, I was working in a team based. So I involved the cardiology registrar,
Mhm.
and I informed about the situation. And after that, we successfully transfer the patient to the for further management. uh,
Mhm.
Apart from that, once the patient got discharged, we can ask the patient to liaise with the GP. While in the hospital, we can involve the rehab team. We can
Yep.
involve the all the allied health people,
Yep.
and we get the opinion from them. So I worked independently, as well as when I needed help, I seek to
Escalated
my
it. Yep.
supervisor
Yep.
or my the other members. Yeah.
Perfect. This is exactly what this question is all about. And you know what? You may think that why is Dr. Tariq answering this question and why rest of the 44 people not answering this question? But Dr. Tariq, you have just improved your understanding of the system. And if you get asked this question in an interview or you're putting your thoughts down on paper, you'll be ahead of those 44 people. I'll trust me on that. That's the difference. Proactiveness is the key. And one of the things that I can vouch for all the people who are good at getting jobs are proactive. They don't let forego any chance of participating actively. So exactly that. So if you've got a patient who's admitted with, as Dr. Tariq was given example of working independently, you've identified a deteriorating patient. So that's related to a skill, that your skills in ALS and BLS in terms of sick patient recognition are there. You need to draw parallels that I understand this patient has got an acute myocardial infarction, has deteriorated with the chest pain, having acute ECG changes in keeping with acute myocardial infarction. It's a time critical emergency. Those are the buzzwords that you need to put in there. And based on the time critical nature of it, immediate escalation to my consultant plus a cardiology registrar on call, and immediate treatment given in terms of antiplatelet, anticoagulation therapy, and escalate the patient whether it needs thrombolysis or definitive treatment in terms of PCI, which is per coronary intervention, percutaneous coronary intervention, like an angiogram and stenting. So that is the wordings. Then if now Dr. Tariq is going to be answering that question, he's going to be answering from level 2. He won't be answering at level 1, which he just did, but he'll be answering at level 2. And then he will get more and more lean in his response. Like his response are going to be much more professional. They're going to be much more, fewer words and fewer lines. And then, it will look good on paper. And that's what gets you shortlisted. And again, as I said, every question needs a narration. So if you can demonstrate that, as a matter of fact, this is one of the things that I've dealt with in my previous job, having work in cardiology section, and these are the patients which we frequently needed to escalate. All right. Okay. Perfect. All right. We just touch base on medical interview quickly before we all finish now. Thank you all for your time. Make sure that you go through your medical application and CVs. And again, the 4 main areas are there: communication, medical expertise, competence, which are skills and courses, clinical governance, quality improvement, and risk management. No matter your questions are your interviews for an intern position or resident position or registrar position, the question domains are essentially within these 4 categories. You can make yourself questions in these 4 areas instead of thinking about the questions which are floating in the market, and be a bit more prejudiced about it. In fact, it is not the way you approach the question. There's no perfect answer to an interview question. It's more like a personal answer. I always say that if you're able to give a personalized answer to the question, that is what's going to get you a job. And that comes from your own personal example. All right. So in terms of practice, when you're practicing for an interview, you can practice with anyone, medical or non-medical. If you can't find anyone, record yourself, and you'll immediately get a feedback as to how do I sound when I'm talking to anyone. The recording is in front of me. How's my facial expression? How am I using my hands in particular? And, I said that whenever you ask a question or somebody asks you a question, answer it in 3 steps. First step is a moment of silence, which should not be beyond like 3 or 4 seconds, so that you organize your thoughts. Define what the question is asking you, like an actual definition, that this question is about the deteriorating patient in terms of skills, in terms of BLS, in terms of time critical emergency. This question is about communication skills, making sure that patient and the relatives understand about the gravity of the situation, like a quick definition. And then you come right and hit the nail on the head is by an example. In fact, funny that you asked that. One of the interesting examples that I've experienced myself is this. So always think of your personal example is your personalized version of that question, which will get you a job. It's not the first 2 which will help. You would be answering the question, don't get me wrong, if you define the question and you're answering the question, but unless and until you define with an example from your personal experience, which is true example, by the way, then it changes the game 100%. All right. So answering a question, again, understand, answer, and as I said, example. We'll do an example quickly. So if I was to ask anyone, I don't know who this Galaxy A71 is, but surely seems to be sending me lots of direct messages. But if anyone would look to hand, like this is a question which got asked during my interview as a GMO when I was applying for a job here at Liverpool Hospital. Would anybody would like to answer this question? Like, up to you, Dr. Maha Parvez, would you like to answer the question? It's not, you can't chat answer interview questions, unfortunately. Okay, you're in office. Sorry, that's all right. Anybody else like to give it a go? Who's not in office? All right. So basically, like, yeah, go for it.
Okay, so this is a 3-week-old boy, and the parents are the first time. So it's really very important to make the patient and the parents comfortable as well, because they might have seen this situation for the first time and they're really worried. So I'll talk to them and make them comfortable and let them know that we are here to help them in the best possible way, and we'll take good care of the kid. So with the kid, first of all, it's really very important to take the vitals. He's 3 weeks old. He has the fever of 39 degrees. So again, we can go with the doctor ABCD approach and take the vitals. We also have to look for the sick child criteria or questionnaire as well, whether the child, the vitals really important, like fever, temperature, blood pressure, and then quickly look for do the primary survey.
Yep.
Then I'll primary survey from head to toe. Is there any rashes on the body? Any
Yep.
the floppy baby is very floppy, anything? And then I have to quickly ask the history from the parents as well, to see what was the real cause. Is there any what could be the etiology or the cause for the fever? It could be my differential, keeping the differentials in my mind. It could be sepsis. It could be an upper respiratory tract or lower respiratory tract infection. It could be a UTI, because she's a kid. So sorry about my kid.
No, that's okay. Completely all right.
So these are the few things which I have to ask, and then have to. But meantime, it's really very important. While I'm doing that, it's really very important because I'm doing the Dr. ABCD, in which I have to look for the help as well. So we have to manage the kid as well from time to time. So yes.
No, perfect. No, that's okay. Thank you very much for that, Dr. Bushra. That was excellent, actually. And you've pretty much plucked all the necessary items. If I was to define an ideal response, let's just say an ideal response to this question, you obviously have got a limited amount of time, and
Yes.
you need to have like a fewer words and sentences to articulate, because there's a panel of 4 or 5 doctors. They want you to just give the information. So you can start, as I said, like take your time and think and organize a framework. So this framework, in my mind, this is a seriously unwell child. This is a neonate, like less than 4 week old. It's technically a neonate. So
Yes.
seriously unwell neonate is coming to my mind. He's at risk of SBI, meaning serious bacterial infection, because all of these temperatures of 39 or 40 degrees, because they have not got immunity. All immunity is based on the IgA factors floating from mom's milk or mom's blood stream into their body. So the immunity is not good. And plus, they're not vaccinated or immunized at this age. So this
Yes.
is a neonate, vulnerable neonate, who has got indication of a serious viral infection, being immunocompromised. That is my thought process still. And my thought process tells me that this child needs an immediate admission, immediate antibiotics, and immediate escalation to the supervisor and admission to a definitive facility. So that's my process. So how about I answer this question? I will answer this question. Okay, look, this is a very serious situation. I understand these parents are very anxious, and quite genuinely so. This is a 3 week immunocompromised neonate who has got indication of serious bacterial infection with a high fever of 39 degrees. This patient needs immediate antibiotic, full septic workup. Don't define every parameter of septic work. Full septic workup, which would be LP, chest X-ray, urine, and what have you. Full septic workup and admission to the pediatric facility with a close, watchful observation. If there's any deterioration in his hemodynamic status, then would need an immediate transfer to the neonatal intensive care unit. That's your definition. Does it make sense?
Yes. Yes.
Yeah. So that's your definition. So example, like you've just given a definition. Every interview was like, yes, this is a safe doctor. So you've just ticked every box in their diaries. All right. Then you say, in fact, in my medical practice, if you've managed such a patient, you can say that we've received such a patient when I was working in neonatal emergency back home in Pakistan, India, Bangladesh, Sri Lanka. And we used to receive these kind of patients because of low vaccination uptake rate. So even though this boy is 3 week old and is not vaccinated, we would still have 6 months who would be poorly vaccinated and would come in with all the parameters of serious bacterial infection. And my priority at that point would be escalation with my senior and getting the immediate antibiotics. My choice of antibiotics would be benzyl penicillin and gentamicin, covering both gram positive, gram negative, and then getting on with the septic workup, because septic workup should not delay the antibiotic treatment of this child. And the septic workup I'd like to do is chest X-ray, urine, and if the child is neurologically stable, ideally a lumbar puncture with complete aseptic technique. We used to admit these patients into the pediatric ward with a close observation, which would be a 1 hourly neuro as well as hemodynamic monitoring. And if there's any deterioration in there between the flags observation, so that's a local term, between the flags, which is heart rate, blood pressure, temperature, oxygen saturation, we would escalate their care to a high dependency unit. So now you've sealed not only the definition, but you've given an example from your experience, which shows that you are legitimately able to look after this patient with the best of your abilities. All right, and this is just a small example. This could be parallel, and if you've not got an example, you can give an example from that point of view, as that I have read about this. There's a strong literature supporting that this child needs to be immediately admitted. Fair game. You don't have to have a neonatal. Not everybody would have a neonatal intensive care or neonatal emergency department experience. You can say that, look, literature is strongly supports that these patients need urgent antibiotic and immediate escalation to the senior supervisor and need an admission for an IV antibiotic in close observation with escalation to the neonatal intensive care unit. You're coming to the same conclusion, not by an experience, but by learning. All right. And you can narrate that, look, I've done an APLS course, I've read an APLS manual, I've actually done an online module on APLS in sick child, all the same thing. All right. Nothing different about it. Any questions from that point of view? No, that's good. All right. Okay. Well, that brings us to the end. Target the job, guys. It's not just about, obviously you have to pass exams on the way through, but you need to target the job. And the exams, if you've done your AMC 1, trust me, you've got all the theoretical knowledge aspects to find yourself a job. Keep applying for job, keep studying for AMC 2 clinical. Do the orientation courses with me if you want to. We've got workshops. You've seen some of the glimpses of our clinical orientation and how relevant those discussions are when you're filling your application forms, when you're working on the floor. Gives you a certain level of in-depth analysis, especially if you've got a career gap of more than 6 months. It ticks off all the CPD hours and take it from there. We a clinical course you can register at emergencyfocus.net. And I'll see you on the first induction class on 1st of April. And if that's all done, I'll leave you here. And thank you very much for all joining.
So just a question, Dr. Rizwan. The clinical orientation and mentor program, quickly a question that is it suitable for someone who have done the clinical? I mean, I get the idea today that it will be more suitable for me as well, because I have done it, the clinical, but again, still from the interview point perspective. So will you recommend that? Yeah.
Absolutely. So
Okay.
in our 3 courses, there were at least, I think, half and half people who have done their clinical. Their feedback was it helps their understanding in terms of how local system works, and obviously it also helps them when they're filling in the application forms, as you've seen that how much it
Yes.
works both ways.
Okay. All right.
All
Thank you.
right. Yeah. So absolutely, if you want to join, if you're sitting, it's something that you can consider quite strongly. Any other questions, guys, before we leave?
Hello, doctor. Good morning.
Good morning, Dr. Esmatara.
Doctor, can you please tell me a little bit regarding the aroma campaign? In which situation we need to do that? And regarding CPD hours, is it necessary to do it before the employment or after getting the letter from the employment? Can you please?
Oh, look, I mean, I think there are 2 recency requirements. Okay. So in terms of CPD requirement, I always tell all my participants that for hospital to take you seriously, you there, Dr. Esmatara?
Yeah,
Yeah.
doctor.
So for the hospital to take you, because when I'm sitting there with a shortlisting panel, if we are taking the application or applicant seriously, we need to see if they, number one, have got as little as possible gap
Okay.
in terms of their clinical practice. That is number one. Number two, their application responses are in keeping with their CV. Like there's no false claims to, like there's no histrionic, there's no elevation of the personal self. They have got truthful answers.
Okay,
And
doctor.
number three, they've shown keenness to work, and they are actually showing that keenness with an active engagement of the CPD. So they're going courses, they're doing physical or in-person courses, they're doing CPD courses. That's what gets you shortlisted. That's the hospital. Because if you're not doing that, trust me,
Yeah,
and I'm
doctor.
not joking, the next
Yeah.
person, the next CV would be doing exactly that. They would
Oh,
have,
okay.
they would have 18 CPD courses. They will have 2 workshops, in-person workshops. They would be making all those links in their application experiences and application responses. They would immediately get shortlisted. Right now, all of
Yeah.
us are competing with all of each other. I won't say competition, there's plenty for everyone, but I would say that the people who are getting shortlisted and getting the jobs are the people who are ticking every box: CPD box, clinical recency requirements fulfillment box. Yes, active
Yeah.
engagement in teaching box, tick. That's why I always see you must be engaged in some sort of a program at all times or CPD activity at all times. Then there's an APRA requirement for the
Yeah.
CPD and your receiving command. You all know about that. We've gone through some of the criteria from that point of view. But before the APRA requirement, you need to bypass the hospital requirement.
Yeah, right, doctor. So, doctor, just I'm asking you, after doing the AMC part 1 and English test, if I'm doing some CPD course, it will be helpful for getting a job, definitely, right, doctor?
Absolutely, absolutely, absolutely.
Yeah.
That's why I was saying in the beginning, you give me your 150 hours in a year, and we'll get you shortlisted at least.
And doctor, little bit regarding RMO campaign, is it mandatory to get a job, or what is the necessary for RMO campaign? Can you?
What do you mean? I don't understand. Like what do you mean?
Doctor, is it? It is for mainly the Queensland Health government services, the RMO campaign. So I don't know
You should
regarding
apply
this
for
campaign.
jobs everywhere. So RMO campaign, if you've got clinical experience in your home country, which is an intern year or a first year resident, you should apply for that RMO campaign. If there's nothing which is limiting you, why would you not apply for an RMO campaign? I guess is my question to you, Dr. Esmatara.
Okay, so what is the necessary requirement for RMO campaign, doctor?
That you should be, I think the explicit requirement would be mentioned on there.
Okay, okay.
If yeah,
So
some
it's
of I mean,
individual,
look, I
doctor,
always say
correct?
yeah, I always say that look, it's demand and supply. If the RMO camping, say for instance, have got, I don't know their real numbers in Queensland, but if say for instance they've got like um 500 jobs, okay,
Okay.
the 400 jobs would be fulfilled by their local interns and resident who are reapplying into that RMO campaign. There
Okay.
is a deficiency of 100 jobs which needs to be filled. And who would they choose then? They would be choosing first time doctors then. So don't disadvantage yourself that I do not qualify for that campaign unless and until it explicitly says that this job, this campaign is only for the doctors who are fully registered, or this doctor who is only who've got at least more than 6 months experience. And now, are the only thing which should define is what level of supervision they are offering. If they're offering level 2 supervision only, then I'd say it's still clarify with the hospital by sending them email, or medical recruitment office by sending them email. But you should be applying. There's no harm in applying. It does not cost you to apply.
Yeah, doctor, got it. Yeah.
Just a quick question, doctor.
Yeah.
If I'm unable to join this, the clinical orientation because of the work commitments, or maybe because of the timing, 10 o'clock to 1 p.m. So in that case, maybe can I check pre-recording sessions online? And
Yeah. So basically, as I said, this program is for you by us. And these are all the things which we've taken into consideration. There'll be 2 sessions in a week, mostly one day in Wednesday. There could be some other day, but weekdays, there's no weekend commitments. If you're unable to attend that session, then it will be uploaded onto the portal that you'll have a password access to. So you can go through that recording. Having said that, you must be mindful that recording always does not provide you with the same level of experience of learning. But if obviously you've got some genuine reason in terms of work, then we can understand that.
And the CPD hours, can I claim
Should
CPD hours as well?
Yeah, look, I mean, because the portal is quite intuitive,
Mhm.
it gives us a direct indication whether you've watched or not. That's why the portal. That's why just not like
Okay.
we are now getting audited by different sources. They send us
Mhm.
an audit forms that how do you know that this participant is participating by watching the video. So I have got an indication of all of those numbers actually down to the very percentage in minutes and seconds. So if you are
Yeah,
using portal, then you'll be getting a certificate based on your portal usage and
sure.
your active participation.
Sounds good, sir. Thank you.
Not a problem. Okay. All right, guys. Any other questions before we leave?
Hi, Dr. Razwan. My name is Oriana. Just want to ask about the observer shifting. If I have a, gap is the more than 8 years or 9 years, is the observer shift in any hospital or GP clinic? Would that be counting as a, gap filling things?
Look, I mean, I think based on a gap of 8 or 9 years, you would need a return to practice and you need to have a professional development plan. My
Yeah.
suggestion would be to have a look at the APRA and return to medical practice guidelines. I think you would need to fulfill the recency requirements.
Yes.
And once you fulfill the recency requirement, you need to have a job offer and have the plan to return to the practice plan. Now, in terms of observation, it will not fulfill the recency requirement because the recency requirements are quite explicit. You need to be paid. It needs to be at least 4 weeks based on your level of gap. So observations are good from the point of view of obviously orientating to the system. But
Yes.
then again, they're not going to fulfill your recency requirement, which I presume you would need
Okay.
for your particular case.
Yes, thank you. Another thing is that if it is that, that if we can get a observership at the
Yep.
GP,
Yep.
that whether be when you are applying the job in the hospital, whether be helpful or only the hospital only take as the observership in the only hospital observership things, not from the, GP
No.
observership.
Look, I mean, I think the circumstances are such any observation is better than no observation. Hospital
Yeah.
observations are particularly very difficult, although not
Yes.
impossible now that with easing COVID restriction, you should have more opportunity. But look, once you've got an observation, just grab hold of it. So if you've got an opportunity of joining a GP observation, join that. All right.
Yes.
In between that time, if you get a hospital one, join that. So
Yeah.
you should not limit. It's same as like applying for a job. It does not cost anything, and the weightage is there. You're getting patient interaction. In fact, I would tell you one thing.
Yeah.
If you go onto the slide before, this is directly from the APRA website in terms of your recency requirements. They might be able to consider the recency requirements of non-clinical work, recency in a non-clinical work, medical administration, teaching, research, or medical policy. So
Would that
if you're
be including as a, working as a phlebotomist? I'm working as a phlebotomist for over
so
6.5 years in here.
yes, so look, I mean, that's the thing that we need to clarify. Some of the people
Yeah.
who've been working in the vaccination center, some of the people who've been working in a capacity of a telemedicine service, they have been able to convince the board that they've had some sort of patient. It must have patient interaction. Phlebotomy, I'm not sure if that has got same level of patient interaction that you're really counseling them. But then again, please double clarify that with the board that if
Yes,
I'm
thank
working
you.
as and if I was to get a recency in a non-clinical capacity with phlebotomy job in particular, help me in addition to clinical observership or in addition to the recency requirements that if I fulfill, I think it should add value and weightage to your CV anyway.
Yeah.
All right.
Yeah.
Now,
Thank
there's
you very
another
much.
question from Dr. Fahad Ali. Sir, please guide about your upcoming clinical course for AMC2 preparation. When is it going to start? And also guide about the cost price of the course. So the next course is starting from the April 4th, I think. Yes, definitely April 4th. And there are two different types of courses. There's a core course and there's a comprehensive course. Core course is basically giving you all the core subjects and similar to comprehensive course, all the content covered is exactly the same. It gives you and access to the online portal, AMC online clinical portal, which has got videos, notes, guidelines, flashcards, and everything, same as comprehensive ones. But the only thing it lacks is does not have recalls classes, but you can purchase recall classes. Plus, it does not come with the trial exam. The comprehensive course does. The core course from memory, I think it's about 699 is the price of the course, core course, which is 6 weeks, I think. And the comprehensive course is comprehensive course is 2000, which is based in 4 installment. I hope it answered your questions. But if you jump onto the website, it will give you all that access, like where the courses are. If you know what I'm talking about, if you've seen or has like, I mean, I get these fair questions. How do I register for the course? I just wanted to highlight, like, you register the course by going on the website, which is emergencyfocus.net. Does everybody know about our website, emergencyfocus.net, or not really? So all the courses are there on the emergencyfocus.net, so you can easily have an access to that. So that's the website. Can you see the screen, guys? I'm trying to share the screen.
Yes.
Okay. So this is our website, emergencyfocus.net. As you can see that it's got section AMC, CPD. So this is this. So if you're wanting to do clinical orientation course, you go to the CPD course, and if you click the CPD, it will open up. If it will at some point. There we go. So it opens up and it just takes you through, like, this is the clinical orientation course. You just press register now. These are different workshops that you can do. They're all in there. All of these. This is the workshop that you're doing right now today, a free online orientation course for IMGs. And if you want to do an AMC one, you just click the AMC and it opens up the AMC. There's a guide for AMC as well. You can read that guide. And then there's a free session of AMC which you can watch. Plus, this is the course that I'm talking about, like 699. It's starting from 4th of April, Monday. And this is the core course, morning session, comprehensive course, morning session. This is the evening core course, and this is the evening comprehensive session. So all the information is there. If you jump onto the website, emergencyfocus.net, and just press the main tab, CPD courses or AMC courses. Any other questions before we finally part our ways, guys?
Yes, Dr. Rizwan. Can you hear me?
I can hear you, Dr. Abida. Yes.
What if someone joins a university course or something? Does that cover the gap, or does it count as?
What sort of
where does that?
university course?
Master's.
Yeah, look, I mean, I think it used to be the thing that everybody was doing MPH, Master of Public Health, and all that. It adds not like a real value in terms of getting you shortlisted MPH, because it's away from the main clinical stream of work. However, in terms of your CPD activity, you could qualify for that. Look, I've been doing masters in the meantime, but my strong encouragement, having seen some of them coming through the master route, is still to maintain some sort of clinical portfolio. Don't just rely on your masters. That's your theoretical aspects in terms of your personal education, which will help you regardless in terms of your CPD points, in terms of your, when you're applying for registration. But having some sort of clinical exposure in terms of observerships or something like that would be excellent. Would be excellent, because if I've got a CV in which somebody is actively involved in some sort of observership or some sort of program, in some sort of work which is clinical, interacting with patient, that is far more reassuring for me than rather a theoretical knowledge about public health. Yeah.
Got that. Thank you very much.
Not a problem. Okay, all right, Dr. Ruhi, are CPD courses helpful only for those whose gap is less than 3 years? CPD courses are helpful for everyone. Please don't get me wrong. They're helpful for everyone. You can do CPD courses if you got more gap, if you got less gap. All of these details are available on our website. Okay, thank you very much. And all the best, guys. I hope that we get to meet again in some form of forum and platform. And I wish you all the best. Stay put, stay persistent, and never lose hope. Don't define yourself with the success and failure of others. Define yourself with your own hard works. And I'm pretty sure that you'll get there. And it's all about, this will all seem like a joke of some sort once you've done you've got a job. It's the first job that you need to. And as I said, if you are able to dedicate 150 hours worth of emphasis in a year, this is a good time to be right now. And yeah, I wish you all the best. Thank you very much. Bye.
Thank you.
Thank you.